Committee Room 29. Sound.
On to today's meeting as our first official Health Committee meeting from the Christmas recess. Today the committee will receive 2 oral briefings from the department. The first one is on January monitoring and the second briefing is on the committee's inquiry into access to palliative care services. The committee will then consider 2 SORs and officials will also be in attendance to provide a very short briefing and answer any questions that members may have on those SORs. We will then consider the LCM for the tobacco and vapes bill and a written briefing on the hospital car parking charges. So just the meeting is now open to the public, and remind members that the committee meeting will be recorded and broadcast throughout Parliament buildings and online, and that members and those in the public gallery are welcome to use public mobile devices as long as they're in airplane mode and all devices are muted. And for anyone that needs to connect to Assembly Wi-Fi, password details are available on the gallery rules, and it's not permitted to take photographs or record any of the meeting. I haven't received any apologies. I'm not sure if members are aware of any other apologies. I think we've most people on now. Anyway, no apologies, no.
Dan's on our way.
Dan's on our way, that's okay. We have Colin McGrath and Linda Dillon are joining us online. Under I suppose just to move to Chairperson's business, just 2 short items I wish to raise. Earlier in the week, myself and Orlia had met with two groups, Mesh Awareness NI and ME Support. I know as a committee we'd also met with Mesh Ireland, and I had attended and chaired the recent Women's Health all-party group as well, where the Sling the Mesh and Mesh Ireland attended a meeting with the Minister in terms of the issues affecting women, and we also have males who are mesh injured. So just to flag that up, in the meeting with Mesh Awareness, they have still a number of issues in relation to that, and I think Orly maybe wanted to raise just.
Yes, well, I was going to suggest maybe if the rest of the committee was content about writing into the department on it and to the Minister. So there was a couple of things around that we're designing a leaflet for GP surgeries, and I think some of that work might have stalled, just to see where that is at, and then reissuing guidance for GPs whenever they're dealing with people that are coming with complications of mesh. And then there was other questions just in terms of informed choice when people were going to get mesh removal surgeries, or even if they're having to have mesh inserted in the first instance, if they had choice whether to go for that or the traditional surgeries that would have been carried out before the implants were brought onto the market. And then just if there is any update, there mightn't be, but if there was any update on the redress scheme, because I know that's been progressing over in England and the department's sort of watching to see how that goes.
Yeah, no, that's fair enough. And the other thing that did come up was the yellow card scheme, and they had been saying that they were concerned that it wasn't generally well advertised, or people didn't really know about it. So it was just to maybe highlight that with the department, see how they ensure people who are impacted are aware of that, and can they review maybe how that is being done. And then we'd also met with the ME support group, and that's another issue, because obviously there's no commission service in place in terms of patients with AME, and indeed I've been working with groups who have around fibromyalgia as well. So I would just ask if we could write to the department to get an update on that, because I know there previously had been funding agreed, but it hasn't progressed. Sorry, Olia.
Sorry, Chair, again, just on that issue around the ME support group. So I do think that's important, because there was funding made available for a post for a specialised consultant in this field, which we've never had before. So it's just to see if the funding is still there, is still available, what's being done for the department to proactively advertise and recruit that post. And then in an answer that I had got from the department a couple of months ago, just in terms of what services are available, we know that there isn't many services available. Basically, it's very hard to get any sort of care pathway, but if we could ask for a breakdown by trust in terms of what services are available specifically for people living with ME or chronic fatigue syndrome, there's different ways of.
Yeah, no, that's grand, Olivia, thank you. Okay, that's all I have under Chair's business. If we move then to the draft minutes, and we have two sets of minutes, one for our last committee meeting on the 12th of December at page 10 of your pack, and for our emergency committee meeting last Tuesday the 7th of January at page 7. Are members content to agree both sets of minutes?
10.
Thank you. Under matters arising, if we could refer members just to the clerk's memo, page 22, which outlines the actions which the committee agreed at the informal meetings held on the 9th of January. Members met with Versus Arthritis, the Obesity Coalition, ARC in relation to antenatal screening, Caleb's Cause and Hourglass. And just supposed to say I found it was an excellent committee clinic, and there was a really, really good engagement with the organisations, and definitely lots of things that we could be taking forward. So I just ask our members content to agree the actions in the memo. Yeah. Okay, then members, will move to item number 5, and this is our first briefing on the 2024-25 January monitoring. If I could refer members to the clerk's memo at page 25. We also have a briefing paper from the department at page 28, and we have a copy of correspondence from the Health Minister to the Finance Minister regarding health spending and assessed need at page 3 of your table papers, which you would have received today, and a written ministerial statement published yesterday regarding an equality impact assessment of the Executive's draft budget for 25-26. It's at page 7 of your table papers. You're all very welcome back.
Thanks.
So in attendance today we have Bridget Worth, Director of Finance, Danielle Mallon, Head of Financial Management, Preda Miller, Investment Director, Brian Dunlop, Capital Resources Unit, and David Keenan, Financial Planning Unit. So we're delighted to have you here today, and we've about 45 minutes for the session. So if you're happy to make some opening remarks, then I'll open up for questions. Thank you.
Okay. Thanks, Chair. I'll start by making a few opening remarks on the January monitoring position and the 25-26 budget on the resource side, and then I'll hand over to Preeta to cover capital. So in terms of January monitoring, as you're aware from our session before Christmas, the department was facing a £100 million shortfall following the October monitoring round compared to what was needed to fully match the pay rises given in England. I indicated at that time that we were undertaking a full review of our position with a view to bridging the gap as far as possible, but that given the scale of the challenge on top of the £200 million of savings already delivered this year, I expected that further executive support would be required to meet the pressure in full. As reported in the paper in front of you, we've managed to narrow that gap to some 35 million through a combination of changes in our estimates for demand-led expenditure, taking some additional risk around anticipated year-end underspend, and a full review of accounting treatments. We've also had a windfall in terms of some additional immigration health surcharge funding. I'm aware that it's unlikely that there'll be sufficient funding available at January monitoring to meet the £35 million bid in full. An additional 10 million of funding at this time would enable us to get 11 months back pay to our HSC workers in their March pay. Beyond that, we'll continue our internal efforts and would also hope that the executive may support us by allocating any further year-end slippage to enable us to make up the remaining difference as soon as possible. Turning to the 25-26 budget then, the resource allocation provided for health has essentially given us an additional 200 million of funding when you compare it to 2024-25. I know you've only seen our EQIA and budget assessment recently, but you can see from the list of pressures in that document that 200 million only goes so far in covering those inescapable pressures. We need to continue to run the health service in its current form. So, for example, 65 million to meet our obligation to pay the national living wage, 36 million to ensure GPs and other providers of health and social care services have the funding they need to afford the increase in employers' national insurance, and 150 million for a 2.8% pay rise, which is the increase the UK government has recommended to the pay review bodies. And I'm at 250 million already, before we even touch on price inflation and the need to address growth in demand for our services. We will, of course, continue to look for savings to enable us to fund some of these pressures, but the capacity for real cash releasing savings is much reduced by the efforts we've made this year to deliver that unprecedented 200 million that we've needed to bridge our 24-25 funding shortfall. And many of those savings weren't repeatable, which means that new measures need to be delivered even just to get us back to the level of savings that was delivered last year. So, The reality is this budget doesn't provide us with the investment that would be needed to make the kind of difference to our services that we'd all like to see. Our level of funding relatively to England is now at a 10-year low at 1.5%. It's significantly below the 4 to 7% that was estimated by the Fiscal Council as being required to meet our additional need. So we need to be realistic about what can be delivered within the envelope we've been given. I do accept, of course, that other departments are also struggling to manage with the allocations they've been given, but if we accept that more funding for health can't be prioritised over the allocations given to other departments, we also have to accept the consequences that that has for the delivery of our health and social care services. I'll hand over to Preeta now to give you an overview of the capital position.
Okay, thank you, Bridget. So for January monitoring, the department submitted 3 bids for capital, totalling 32.8 million. These included 20.5 for the pandemic preparedness stockpile of PPE and hygiene consumables, 6.7 million for replacement medical equipment across trusts, including, for example, a CT scanner, obstetric probes, a vascular ultrasound scanner, and a mobile radiography unit. This bid also included funding to assess health and safety risks, including replacement windows and locks, upgrade works to the helipad at Craigavon Area Hospital to comply with new standards, refurbishment works that will enable the creation of a neurology outpatients hub in South Eastern Trust, and vehicle fleet replacement. Then there was 5.6 million to refresh existing IT infrastructure, and that is networks and servers across the HSC, and to fund new software licences. In the event that the bids aren't met, these pressures will carry forward into the next financial year and add to an extremely difficult financial outlook. The department's proposed allocation for 25-26 is 391 million. This is less than what we require to fund our committed projects, critical ICT, and to maintain our existing services. It does not provide the funding required to progress new capital investment. Bridget outlined that the overall funding position relative to England is now at a 10-year low. The comparison for capital alone is even more stark than that. Our investment is lagging behind at about 5% less in 24-25 and almost 16% less going into 25-26. So without additional investment, it's inevitable that the estate will continue to deteriorate, while the pace at which we can deliver the new estate facilities that we require will have to be slowed down to fit within our budget allocation. So that concludes my opening remarks, and we're happy to take any questions.
Thank you, Bridget and Prada. I appreciate that. I suppose I'll just go straight into it. I suppose more a comment than anything, but I think your point around our funding position being at a 10-year low in comparison to England really reinforces the point that we need Westminster to step in. And I think the Minister has said that even this week about the need for the increased overall funding. And I'm hoping then that the Minister will be making that case, because I think, particularly when you even look at, I think Bridget, you had outlined that potentially the allocation in this monitor round is around 10 million. Tells me that the executive budget is stretched beyond capacity, and that just highlights just how much health has got as much as possible, and still, we would have expected maybe there would have been more slippage, and that hasn't, because all departments are really to the wire. I suppose just on that then, in terms of the coming to year end, has the department any concerns that there might be any particular underspend or any overspend? Are we content that the full budget will be spent?
I suppose in terms of the resource budget, obviously we're waiting the outcome of January monitoring, and indeed by the time this session finishes we may know the outcome of January monitoring. But my expectation is that we will still, as we move into year end, be looking for every penny of slippage we can to attempt to bridge that, what I expect to be a remaining gap on the pay settlement. Now, if that funding doesn't come this year, I think the Minister's made the commitment to fund it out of next year's budget. So in that context, I expect that we will be in a position to break even, but it's a question of how much more can we push to get that full pay settlement to our HSC workers as soon as we can.
And I suppose that was going to be my next question in relation to the pay, because it was very welcome that an agreement was reached. And I would hate to think that there would be any delays if they can be avoided. So, given that the time frame we're talking now, we're 2 months really, essentially from the end of the financial year, is it likely that that will still be able to be made in a timely manner then, you know, even with the extra slippage?
So our expectation is that there will be a payment made in people's March pay at the moment. We're still on target for that. The question is how much of the 12-month arrears we're able to pay in March. It looks to me as though it's most likely that we will be in a position to do 11 months. Now we're not yet looking at, we're looking at enough funding to do 10 months already. We need to see what the outcome of January monitoring is, but I'm hopeful that by the end of January, which is roughly when we need to make the call on that payment, we will be able to say, yes, okay, go ahead with 11 months, and we'll then just be continuing, as I say, to look for slippage, and hopefully other executive departments, if they've slippage, that they can return to the centre. If the executive were to agree that that can be passed over to health, we would hope that that might be enough to do the final month. Now, I mean, that will then have to be processed through the payroll, so it will be, you know, we'll actually get paid for a while after that, but, you know, obviously we would want that to be made as soon as we can.
And I'm not sure if you can answer this, but just is the Minister of the Department continuing to engage with the trade unions, particularly on this, so that they're kept abreast of what's happening? I'm sure that they are. Sure that they are. I know there's been, you know, continual engagement between our workforce policy colleagues and trade unions. Okay, no, thank you. In relation to the bid for PPE, and I think Diane had previously asked some questions around this as well, I suppose it's just to get an understanding of what the current stock of PPE is. And I mean, given, I suppose, the pressures over the winter period that we've seen, particularly in recent weeks, and that are continuing, what that looks like, and then what that additional 20.5 million will provide.
Okay, so I'm going to try to explain this in a way that it can be digested. So the capital budget requirement for the stockpile is linked to the revenue budget position. So the PPE is currently being held in the BSO warehouse. It will not purchase the PPE, but the correct accounting treatment for any PPE that you're going to hold rather than treat as a consumable is to have it capitalised. Mm-hmm. So when that funding, when we get that funding, or if we get that funding to capitalise the PPE, there'll be a corresponding easement in the revenue budget that will obviously assist the revenue budget position. Okay, and see, just in terms of PPE, is that for things that are used all year round, or is that in the event of weather, you know, for example, with a flu outbreak? Or
take that one. I mean, effectively, it's both.
Okay.
So, you know, we still have a significant stock in our warehouses from pandemic times. So we're overstocked effectively in the warehouse at the moment compared to the normal usage pattern. Now that will change as that stock expires and has to be disposed of. So at some point we will actually have to purchase contingency stock. Yeah. But at the moment we still have quite a lot. From the peak of pandemic when we were purchasing and the rate of usage was much higher. Now I don't know the statistics, but I know, for example, the rate of use of PPE would have been much higher during the pandemic even than over like a bad winter period. Mm-hmm. So, you know, the rate of, you know, the need for a stockpile is because in pandemic time particularly in COVID we just went through it multiples of times more than you would during normal times. Yeah. Okay. I don't know if you know if that's probably. No, I don't know any more than you. Yeah, sorry, we're not. We, you know, the guys from BSO would be able to give you a chat on it. Get an understanding of it. Yeah, do you want to come in?
I just wanted to ask just supplementary on that, and this might seem like a stupid question, but just you know, in other areas of the health service, sometimes things become unusable. So does that come into account in terms of, like, I don't think the word is like out of date, but you know,
it is. So things like some of our PPE actually has a use by date on it.
So is there a lot of waste then?
So there is some. There has been some waste. There has been some PPE that has needed to be written off. And again, I don't have the full detail here, but we have certainly had to...
The figures, or do we think we're looking at?
So, I mean, at the end of last year, I've forgotten the number from last year, but we wrote most of the surplus off in the 23-24 financial year, and I can't remember off the top of my head how much it was, but it was tens of millions that we now we didn't dispose of that all at that time, but basically what we did was we ran a model that says if we continue our PPE usage at the current rate, how much will we use before it's used by date? And at that time, that was the assessment of how much would be surplus. So we continue to look for alternative uses for that, and the stuff that hasn't, some of this stuff doesn't go out of date for a year, 2 years, 3 years, and we continue to work with the other 4 nations to see, does somebody else need it for their pandemic stock? Looking for alternatives to ways of disposing of it. Again, not the expert here, but we do our best. But it's back to that, at the time of the pandemic, you would rather be looking at it than looking for it.
Yeah.
I'll come back.
No. So I think Diane will just come in on this point, and then I'll move on to some other questions.
Just very briefly. So I did ask a question on this, on PPE that was going out of stock. So last year in 2024, 13 million, which expired 13,061,000. This year, 49 million, or almost 50 million pounds is going to go expire, and next year we will add another almost 22 million onto that. So just to clarify, you're saying that this is an accounting mechanism, the bid for more PPE?
So what's happened is there's two things happening here. First of all, in terms of, there's a difference between when we write something off and when we write it down in accounting terms. So the write-off happens when it's actually reached its use-by date. The write-down happened, most of those numbers that you've quoted would actually have been written down in accounting terms in 23-24, because we, at that point in time, would have known that it was going to expire without being used. So in budget terms, most of that stock that expired actually hit the 23-24 budget. Yes. So the figures you're quoting aren't hitting the future budget. What's happening on the capital side is some of that stock which... But
the stock that's due to expire in 2025 is £49,670,215, according to this. That's the figure that came back in the... So that's due to expire in 2025. That's almost £50 million. How will that be treated, and what are we saying about that? Is that 50 million just simply lost? For those of us who aren't accountants, who don't know how this is actually going to work, is that lost?
That 50 million was lost in 23-24. So even
though you're writing it down in 25?
So we're writing it off in 2025. In 23-24, we would have said, we know that we're not going to use this in time, but we're going to write the value of it for accounting purposes down to 0, because we know that we won't use it because it will expire in 2025, and we're not using PPE at a rate that it will get used by then. So in 2025, we're not going to get rid of it. We're not going to throw it out until it actually reaches its use-by date, and that's the point at which we then formally write it off. And so if you've asked the question about write-off, you'll be getting the point at which it reaches its expiry date. Does that make sense? So,
I mean, the question I actually asked is between 2024 and 28, what will be the breakdown of PPE that will expire? It is 96,797,000, the total amount. It's incredible. 96. It's here. It's in the answer to the question.
It's written down, written off.
It's 96 million.
It is a cost, but at the same time, remember, during the pandemic, we we were really scared that we were going to run out of PPE.
Oh, no, I accept that.
So,
I accept that entirely. I do, Bridget. I do accept that entirely. But I'm just saying that is an enormous cost to the health service.
It was just
sorry, Chair.
No,
thank
you're
you for letting me in.
no problem.
Thank you.
And I think it's an important conversation because these, I suppose, those kind of nitty-gritty kind of points are good for us to understand as a committee. I mean, would it be fair to say then, now that we are past the pandemic, you wouldn't see those types of figures in normal times, and that we can even look at that and learn from it to say, right, for future planning you would have a stock but nothing to the...
So difficult, isn't it? Because I think all the all the conversations that we've obviously had with colleagues is that at the time there was such a long lead-in time. There was the fear that you actually wouldn't even get the PPE. So it's so difficult to say that there's a definitive set of rules you could apply to a future pandemic. I think everyone was making the best call they could with the information they had at that time. And it's just now we're basically living through the writing down and writing off.
But certainly in terms of what would be written off in normal times, there would always be a low level of write-off, but it would be nothing like that kind of level. I mean, I don't have a history of it, but I mean, I'd be surprised if it hit much more than... I'd actually be surprised if it hit 1 million in a normal year.
And that's even...
But don't quote me on that, do you know what I mean?
No, but I understand what you're saying. Okay, look, I suppose it is good to have that information. It's something we probably want to keep an eye on, in the sense that we make sure that we're getting the best use of the stock that's still in date, without ordering reams and reams of stuff that then means that we're going to have huge wastage in the time ahead. Because like when you think even in the last year, 100 million is what was needed to cover the pay ask. I know it's not comparable, but essentially if it's money that we had that we didn't spend, and that you understand where I'm coming from. So it can be very easy to look at where money could be better used, but I suppose we're dealing with something that was completely unforeseen as well. So thank you for that. Just in relation to I've just one or two short questions to finish up. In terms of the next year's budget, I mean, we've talked in the past around the usage of agency staff, locum staff. Are there any targets in relation to reducing the levels of spend in those areas moving forward?
We haven't set targets yet, but we're certainly looking at that. I mean, agency reduction spend is one of the real success stories of the last sort of year or so. I mean, we're forecasting in 24-25 to have reduced agency spend by 57 million over the base year of 22-23, which is an additional 40 million compared to last year. Our attention is turning now more to medical locums. That's a lot more complex because obviously you've got a lot more different specialisms involved there. But we are talking about whether it's feasible and what sort of level of target we might set for the reduction of locum spend into 25-26. We just haven't got to the point yet where we've worked out what we think a reasonable target might be. Yeah, okay. I'd be keen to hear some more about that when information is available. And I suppose then that to ensure that if where possible those savings, as if they're made, if that's then reinvested into stabilising those services that actually use locum and agency staff. And my final question just on that, given the recent pressures, I would assume a lot more agency staff maybe were needed to try and alleviate in hospitals, particularly because staff would have maybe had to go off sick due to the flu and things like that have impacted. Did we see... Because I know when we had the committee meeting last week and we had the Minister in and we had the PHA in, and they said that the numbers in hospital were much higher than were even predicted. So in terms of the winter preparedness plan, and I would imagine there was some agency staff factored into the monies around that. Did we see a jump in what was needed to cover that, or are we not at that stage yet? I don't know yet. I mean, we will get our the period ending December. We don't get financial returns in until towards the end of this month. I'm not hearing from trusts that they've used perhaps more than they were expected. I'm not hearing from trusts that they're concerned that they're starting to go off plan, and that it's causing them to have concerns about break even. I'm not hearing that. So I'm expecting that. I'm not suggesting that the use of agency staff wasn't higher, but I suppose what I'm suggesting is it maybe wasn't significantly causing them to go off plan. At least not to the extent where they're flagging major problems to me. So
well, look, I mean, anything coming back from that would be useful for us to hear as well, if possible. Okay, thank you. I have Colin online.
Thanks very much, Chair, and thank you for the presentation. Just a couple of quick questions. Maybe there's been more than one reference over the last number of days and again today about this comparison to the English model. So it's just two little elements of that. Has there been any influence upon the costs that are there in terms of transformation, which will have taken place in England and Wales at pace but hasn't taken place here? Has that had any impact on the finance that's made available to health services in England, and therefore that we need more because we haven't done any transformation? And is there any impact at all in terms of the impact of the connectivity between health and social care? Because I do remember the point being raised that in terms of social care, because it's part of councils in England and Wales, that if there's higher costs, they're obviously able to adjust their income levels via local rates. Whereas here we don't have any ability really to revenue raise to be able to cope with that. It just has to come out of the budget. So do those matters impact upon the budgets in any way?
If I could take the second bit first. So the percentage there that I'm quoting is based on health spend only. As you rightly point out, because social care is treated so differently in England, it's very difficult for us to get a comparator of social care spend to actually understand to what extent we are or aren't spending in line with England on social care spend. So it's a lot less easy to get at that comparator, and certainly it's a lot less transparent in terms of what comes across as Barnet. You can see health Barnet very clearly. It's very difficult to see social care Barnet because all you see is local government Barnet. You don't know how much of it is social care and how much of it isn't. So there's definitely something in what you're saying, but it's incredibly difficult to quantify how much it might be, if that makes sense. And then the first point around transformation, I think we all accept that our system that there is room for our system to be more efficient, and that some transformation can help with that. I think the difficulty in the context of a funding gap is that a lot of the time that transformation and greater efficiency, it will treat more patients with the same amount of money, but it doesn't contribute to releasing cash towards a funding gap. So it can be difficult, for us to, the transformation in itself won't reduce health cost. It will slow the rate of growth of health cost, and it will mean that we can do more with what we've got. Does that answer your question, kind of? Yeah,
I mean, it's just really, I suppose the point is, I've heard you mentioning the report today, and I heard the Minister mentioning it on the radio this morning and in a press statement yesterday. So it sounds like it's now becoming a soundbite from the department. So just wanted to interrogate it a little bit in terms of what it actually, in reality, can you take the two systems and compare them? And I think in reality, the systems are so different, it is very difficult just to draw that direct comparison to say they're getting more than us and that's not fair. Although that said, if I can help in any way to shout and argue for more money from England, I'll certainly do it. But it was just to acknowledge that direct comparison between the two services, it is nigh impossible.
Yeah, I suppose, but it still gives us a sense that what we're saying is that our system, if it was running as efficiently as England, would still need 4 to 7% more to deliver the same outcomes. And what we're saying is, so we're now at a point where even if our system was efficient as England, whilst recognising that it isn't, we would still be struggling to deliver the same outcomes. I think that's the point we're trying to make.
Okay.
Obviously, if our system was more efficient, we would be getting closer to English outcomes.
Yeah. Okay. No, look, I appreciate that. The final question just then is in terms of the January monitoring, I suppose, which is what you're here for, really. Was there a bid made for waiting list initiatives, and to what level would that have been, and then what level is that projected for next year? I mean, we've seen an incredibly powerful report today from the RCM in terms of corridor care, and the statistics in it are mind-blowing about how just normalised corridor care is becoming as part of our health service here. And obviously, if we can make waiting lists more efficient and we can try and clear the backlog that there is there, that would assist the system in trying to reduce the need for corridor care. So was there a bid made as part of the January monies, and is there any increase in next year's budgets to tackle waiting lists?
So turning to the January monitoring first, we made a bid for 1.5 million in January monitoring. Now, I mean, obviously that's a relatively modest amount of money, but the reality is we're so close to the year end that our ability to get money spent in the last sort of weeks of the financial year is limited. So that's what we've bid for this year in January monitoring. I think the combined total of our bids for next year were around about the £300 million mark. Now, the funding obviously that we've received won't enable us to get to that, but what we have set out in our EQIA is a under the sort of financial planning scenario that we're starting to work on and see how feasible it is, that we would be able to maintain the level of funding that we put in additional in 24-25. So we're looking at 76 million of that 300 million in the financial planning scenario that that leaves us with that £400 million gap.
Yeah, if we could just leave the point on whatever we could do in the North-South scheme, where people can go and get their operations in the South and then claim the money back. We all, I think, in constituency offices have queues out through the door if people want the avail of that. I think it would help. It doesn't require extra staffing. It just is a direction of the funding, and it would be very, very useful. So if there's any way to try and encourage the development of that scheme for the North-South Health Initiative, we really, really appreciate it. But thank you for your answers and thank you for your presentation. Thank you.
Thank you, Colin. Danny?
Thank you, Chair. I just wanted to ask a couple of questions. You'd mentioned the 65 million that was saved. Could we get a breakdown of that? You'd given us a couple of headlines as to where it came from. You mentioned a windfall from immigration and a couple of other headlines where that made up that 65 million. Could you break that 65 million down for us?
Yep.
And just explain the immigration one as well.
Yeah, so essentially on the immigration health surcharge, that's an amount of money that comes to us from the Home Office. It's our share of the visa money that people pay when they come into the UK, and we're reliant really on Home Office estimates for that. So we were not expecting a revised estimate that came in that basically said you're getting £7 million more than the previous estimate we gave you. So that was very much thank you very much, we'll take it. So some of the other things that have happened that contribute to that 65 million, we've had 25 million from engaging with trusts around, what more can be done to try to bridge the gap. Most of that came from reduced demand in terms of high cost drugs. So where you're simply, it's not denying people drugs, it's just you estimate how much you're going to need, how many people are going to come forward for certain treatments at the start of the year, and then the reality has come in lower than what was forecast. So there's a significant amount from there. And then we've also had drug prices have been coming down in recent months as well, which again we weren't expecting. So there's contribution from that too.
These are all kind of fortunate things that have happened.
They are. I mean, look, it's a big budget. We have to make assumptions at the start of the year. A lot of our services are demand-led and are driven by pricing that's outside of our control. So you make a set of assumptions based on experience, previous year's spend, what you expect to happen in a year, whether demand is growing or falling, and then, as you say, we've been fortunate that some of those estimates have been on the high side, and we've started to see as the year goes on that those easements coming out.
So they're not exactly savings that have come from efficiencies or anything like that. It's because of a set of fortunate circumstances.
Yes, I think that's fair. I think that's a fair
And
comment.
it could go the other way next year.
It could indeed go the other way. In fact, well, I suppose we're all hoping it doesn't go the other way between now and the year end, but you know, that there's always risk. But the closer to the year end you get, the less risk there is, because obviously there's less of a time frame for something to change.
Okay. Just out of the 65 million, 7 million of it was from the immigration?
That's correct, yes.
Okay. No problem. I wanted just to dig a wee bit deeper into the PPE. Now, certainly as someone who worked in the hospitals during COVID, very aware of how important it is to have PPE, and particularly at the start we were very, very thin on PPE, and it was a very worrying time. So it's right that we do have a stock. How is the level of stock required calculated? Is there a national level that you have to keep for certain emergencies like a pandemic? Would you be able to answer that first?
So I think the amount that there was required to be capitalised, I think there were models applied around that. I'm not very close to what modelling was done. Emergency planning in the department would look after that, but I think there are metrics that they used, and they ran several models, and they came up with the amount that we need. But the recommendation came nationally, to have on a 4-nation basis, to have a pandemic preparedness stockpile. Just that was a learning from the previous pandemic.
And that level, the level that we have of PPE is based on the population, is that?
Yes.
And we meet that level safely at the minute, that there's
We
a
have
required level.
we have the PPE.
Mm-hmm.
So the bid was largely to reflect the correct accounting treatment of that stock of PPE as a stockpile.
Okay. I want to dig in just what Diane was saying about 100 million's worth of PPE that effectively is not going to be used is shocking.
Mm-hmm.
That is incredible. And lessons from the pandemic certainly absolutely have to be made. We do need a PPE stockpile. That's very important. Is there no system of managing that? Because obviously the trusts will be buying PPE for normal daily use. And do we know how much the trusts are spending on PPE on a regular?
I don't have that figure off the top of my head, but certainly what's happening in the warehouse is the PPE that's closest to its use by date is going to the trust for their day-to-day use.
This is happening?
Mm-hmm.
Yes, 100%, absolutely. It's just that the amount we were using during COVID is just so many times in excess of what we use in daily normal times that is just more than we can use in normal use. So we've that's what's happening. So if we've not put this in a separate warehouse and said it can't be used for general use.
It's continually being used.
It's continually being used. It's just there's more of it than we can use, unless we don't want to start using it for the sake of using it, for example.
No, absolutely. Some of it is going to have to be disposed of. Is that the case?
Yes.
And previously we have disposed of how much, did you say, recently in 23, 24?
Diane actually was the one who had the numbers on that, ironically, I'm afraid.
So 24 we disposed, 24, the way it's written for me, just over 13 million was expired. 25, 49,670,000, so 215. 26, 21 million. It's decreasing obviously because the stock is decreasing, and 12 million in 2027, and by 2028 none. So by 2027 we've finished with potentially expired. Like some of it, so it won't actually be all of that because we're using it as well.
Well, that I imagine...
That was an answer in a point in time. Although it's an answer I put down in September, so it's not that out of date.
I imagine as well that they will have taken account of what they expect to be used in the meantime and giving you those future years.
So you think
numbers.
that those are possibly more accurate? All right, I was giving you some leeway on it, but anyway, there you go.
No,
that's very upright.
Yeah, but I mean, it does just depend on obviously on usage levels. Those usage levels can fluctuate, but I'm guessing that they will have taken off expected usage from those numbers.
Sorry, just when you mentioned that it is still being used within circulation, are the likes of GP surgeries or the likes of nursing homes, are they able to have access to that as well then?
I don't know the answer to that question, but I know that BSO are exploring all avenues that they can to ensure that all of it is used rather than going to waste.
Absolutely.
Do they not do that? Is it like a regular thing? I mean, surely that's
so
something.
BSO buys for the health service. They don't buy for the independent sector and GPs who are independent practitioners.
But all healthcare should be free at the point of entry, you know. So at some point there will be a saving elsewhere if we're trying to.
No, as I say, but that's I suppose that's the practice. I know during COVID that there were systems put in place to enable care homes and GPs and things to take PPE, but they routinely buy for themselves. But as I say, I know BSO if BSO are exploring all of those avenues, so I'm sure that will have been looked at in terms of
Certainly good to hear if we have a stockpile that is about to go out of date, and we have a lot of care homes and we have a lot of GP surgeries and places like that could potentially avail of that. I'm sure BSO are looking into it, as you say.
I know that they're exploring every avenue. I just don't know the detail.
Can I ask just one last?
Maybe get that information from whoever.
One last question, just about the pay deal. Now I appreciate it was going to be 10 months and 2 months. Was my understanding of.
Yes, as I say, I'm waiting on the outcome of June monitoring and on and on the next month's worth of figures. But I'm hoping that we'll be in a position to make that 11 months and 1 month.
11 months and 1 month. So when would the 11 months be paid?
So we're currently on target to pay it in March pay.
Will be in the March pay, and then a subsequent payment then of 1 month's back pay. When would that be? So
it depends on at what point we're looking at the funding. So the sooner we get the funding, the sooner we'll be able to get it into pay. But there's a 2 or 3 month lead-in time. So to get it into pay packets, just in terms of payroll processing. Okay.
And given the earlier suggestion of what the pay recommendation is going to be this year, will there be a subsequent payment within the next 12 months then for this year's pay deal?
For 25-26 pay? Well, obviously we don't know when that pay recommendation is coming through. We are looking at a £400 million funding gap in the department. So our plan that we've set out in the EQIA is looking at can we make savings to obviously deliver that 2.8 estimated level in full, but we know that delivering another 200 million savings on top of the 200 million they delivered last year will be incredibly challenging for trusts. So there will probably come a point in time where we may have to make a choice between services and pay.
Because remember the recommendation was made in July last year and the payment was made in GB in October, I think. So if the recommendation is made earlier this year, there could be, again, another period whereby staff here in Northern Ireland then would fall out of parity.
I know that's not what the Minister would want, but I have, based on the financial position, I would have concerns that we won't be in a position to know that we have the funding for it in that timeline. But obviously, it would be up to the Minister to decide what to do at that point in time.
Thank you.
Yeah, thank you. Nuala?
Thank you. Thanks for coming today and for the briefing. I have a few questions and forgive me if they seem like kind of simple questions, but I just want to make sure that my understanding is correct. One focusing on procurement and another focusing on kind of following on from what Colin said around the spend here. My understanding is we do spend more per head in Northern Ireland than they do in England, and we have had 10 years where we have fallen behind in terms of the level of spend, not per head, but the amount of spend compared to England. I know I'm simplifying it a lot, but still per head it's more here than in England, despite us falling behind over a 10-year period with regards to the percentages of the spend. I just want to kind of understand that a little bit more, and why that why we ultimately spend here more per head in Northern Ireland and our outcomes aren't any better?
So, do my best. The Fiscal Council is basically, their report estimated that we would probably need to spend between £4 and £7 a head more to get the same outcomes as England. So in the past, yes, we have had premiums in excess of that, and it has been probably I suppose so that there are inefficiencies in our system compared to England. Some of those are capable of being driven out. So if you're talking about levels of do not attend, theatre usage, the amount of operations done per day, things like that, some of those are capable of being changed, and there are actions that colleagues in the department and in the trust are constantly doing to try to do that. And then there are inherent inefficiencies in our system that it will be well nigh impossible to drive out due to the fact that we don't have the economies of scale that they have in England in terms of the amounts of people that they're treating and the population size. So there will always be inherent inefficiencies in the Northern Ireland system compared to England.
Can you give examples?
So I'll try. So for example, I'm trying to think, we'll have regional hospitals that have got lower throughput of operations, and some of that can be addressed maybe through the sort of reorganisation of our hospital network. But even if you think about the overhead of our policy making, we're making policy for a population of 1.9 million people. You need the same number of people broadly to make policy as you do for a much bigger population. So there are some inherent inefficiencies in our system because of its size. I don't think I've done a particularly good job.
I think I have an example, and I don't have the exact numbers, but in the digital platform you see it a little bit. So when you're procuring software licenses, for example, and as such, the NHS is so much bigger that actually the unit price per license is much lower, but you're then basically into negotiation with contractors, and it's trying to onboard onto some of those agreements, which I know my digital colleagues try and do, and it's just not always possible. But so there are things like that where actually the buying power is so much greater nationally than it is in GB than it is here, and we do suffer a bit from that.
And could that buying power you're talking about digital, okay?
Yeah.
Is that reflected in the actual health kind of health, like hardware? I want to say use the word hardware. If we're talking about software hardware like medicines, tools, etc. Is it the same in that capacity?
I think with medicines there is a national drug tariff. So I mean we do take part in national agreements around drugs. So I don't think it would be as prevalent in drugs.
The harder angle there is like actually getting access to it for it to come over and supply it here in Northern Ireland. Is that difficult in that?
I don't know. Sorry, I'm not going to attempt.
That's fair enough. Yeah, it wasn't where it was going anyway. But you did mention the waiting lists, for example, and there are other things like winter pressures and annual pressures, and this year does seem to be particularly bad. But we also hear about national news, like it's not like the UK is not, their waiting lists are very bad. There are some areas where their waiting lists are extremely bad, and then we've also seen that the winter pressures are also bad. So that's not unique here to Northern Ireland. So I'm really struggling to understand why we continue to spend more. If my maths are correct, and I say a big massive if my maths are correct, it is £155 more per head for Northern Ireland compared to the 7 whenever we did our last research. It's 2,272 for England and over 2,400 for Northern Ireland. So there's a massive gap to get from that 150 to the 4 to 7. It's just about how we can actually match our policy with our financial decision makers so that we can we can reach that space. Is that something that you feel is actually being done within the department, and both between the department, SPPG and the trusts?
I mean, I think we have lots of concrete examples, particularly in the elective care space, of good work that's going on there to maximise theatre capacity. They've had the Getting It Right First Time team in, looking at a lot of specialities, looking at how we improve our pathways and become more efficient in our delivery. And I think the Minister's 3-year plan had set out that if we primarily through reducing the number of do not attends at some of our appointments, there's the potential for 46,000 additional outpatient appointments and 11,000 additional treatments by the time we get to 2027. So that work absolutely is ongoing, because obviously the more we can get from a pound of investment, the better.
I think it is important to highlight the elective care hubs that you said, for an example, as one of the prime examples of doing well that could over time be built up even more. And the other issue that you raised as well as waiting lists was, you mentioned very briefly, but around people, in terms of the decisions being made by people compared to the population that we have here in other authorities across the UK. What exactly did you mean by that? Do you mean that we still have the same size of management within Northern Ireland compared to others when it's completely unnecessary? I don't know what you meant by that, and I don't want to mishear what you meant.
And I've forgotten what exactly it was I said. Do you mean, I talked about policy making.
For a population of 1.5.
Yeah, so I mean,
and you said we have the same people, the same volume of people making those decisions here as elsewhere. So
yeah,
do we have too many?
No, sorry, I've probably typed myself a little bit and not said. But I suppose the point I'm making is, broadly, policy making for a population of 1.9 million is the same as policy making for a larger population. So you don't have the same economies of scale in terms of the policy teams here compared to, you haven't got a proportionately smaller policy, although we don't, I'm not suggesting we have the same number of policy makers as they have in England, but
better then. Why don't we work better collaboratively in order so that doesn't happen? I mean, I mentioned the likes of the bowel cancer screening, and I understand the reason why we haven't reduced it to 50. I can be unhappy with it and understanding of it at the same time, but there are other issues like that in the preventative side, where why do we reinvent the wheel and copy other people's homework rather than collaborate on a greater scale? That's probably something not for you, for the department instead, and we will pick up on it, but it just seems a lot of.
And I know that, because, as I say, we can't have policy teams that are actually the same size as England, I know there's a lot of collaboration does go on. I couldn't give you specific examples off the top of my head, but, maybe hasn't been a particularly good example, but it is just illustrating that ideally it takes the same amount of effort to make policy in the two jurisdictions. But as you say, part of the way of getting around that is working very closely with colleagues across the water and collaborating on that.
And the colleagues in the Republic as well. And before I move on to my last question, what I would say is just regarding the cross-border directive, plus also regarding the reimbursement scheme as well. One thing that I would worry about is that the cash flow of everyone is not the same across Northern Ireland, and it would drive poverty levels even more for those awaiting for that reimbursement. So whilst it's something that should be open to people, it's not something that we would hail as a kind of outcome that would be better for everyone, because it's simply not. And I understand that the department probably feels the same as well. It's something that, in terms of poverty levels here, allowing those who have the means to actually get there in the first instance. So it's mechanisms that can help all rather than a few. It's not a question to you because it's not your decision, but it's just something I wanted to put on the record. And my last question is around the procurement. There was an article last week regarding the procurement and the limited assurance of the procurement of independent nursing home contracts, and it noted that there was limited assurance provided and my understanding is that is a low level of confidence in independent nursing home contracts provided, between the health and social care and those independent nursing home contracts. But we're talking over 619 million pounds. And I just want to ask if you can feed any more detail onto that, and as to why we're talking about limited insurance, and specifically as well, there has been a lot in the media in the past few days and weeks about ensuring those people who are medically fit to leave hospital into care homes or with family. And it's targeted towards those people that are in hospital, and I actually think it's not a great look, because people, if they weren't in hospital, they wouldn't be in hospital. If they didn't want to be there, if they weren't sick, they would go home or into a care home. But we have an issue within a lot of care homes here in Northern Ireland, independent sector, and we have a lot of issues with transfers into care homes. And I'm not saying with staff, but with RQIA reports, with confidence levels. At what point does finance meet policy, meet best patient outcomes when it comes to over £600 million of money being spent into social care, but we are not seeing better outcomes? That is a big question. I understand that,
and I suppose I expect that's is that an internal audit report that's in a trust, or an RQIA report? Apologies, because I'm not familiar with it, but I mean, I think something that we all struggle with all the time is that balance between patient safety, outcomes and finance, and it's trying to balance those things against each other, because we all try not to let financial constraint have a detrimental impact on patients, but we know the system is such that is not possible in all cases at the moment.
And I understand that completely, but the over 600 million doesn't sound like financial constraints, and it was in annual reports published by the health trusts at the end of the 23-24 year.
Yes, so
but 600 million is not a financial constraint, and there was a review supposed to be carried out. It was recommended in 2018, and it still hasn't been done. It just seems a large sum of money for low level of confidence, and what are the patient outcomes that we're seeing, and it does feed into the current winter pressures too. I think it is actually quite relevant. Don't expect to give the answers here today. I'm content for a follow-up afterwards, and perhaps we can liaise directly with the department, because I understand that if you're not aware of it, that it's unfair to ask.
And it will be actually in the health and social care trusts themselves. So it will be the trusts who are primarily responsible for addressing those recommendations, although I know there's a need probably for some regional enablement of that as well, but I think I'm just not sufficiently familiar with it to give you a comment at the moment.
That's fine, that's understandable. I'll follow up in writing. So
thank you, Diane.
Thank you, Chair, and thank you for the presentation, and my apologies. I was just a little bit delayed at another meeting, so my apologies for being a little bit late. So I just want to ask a few questions which sort of veer from the actual presentation on the January monitoring to some planning that you may or may not be doing for the next year's budget. So in your planning for next year's budget, what amount of money have you set aside or presumed or estimated for a new health SAR, as the Minister potentially announced this morning?
I'm sure you'll appreciate that's impossible for me to answer at the moment.
Okay. I'm presuming you have an amount of money in mind that you have. Some of us are taken aback a little in that we have a number of trusts, chairs and chief executives of those trusts earn a significant amount of money, and we would be adding to the top, another layer on top of that, if we go ahead with a potential health SAR. So I'm just wondering, you're bound to be planning for it, so no.
I don't have a specific amount that I can give to you today.
Okay, that's fine. I just had to ask it because it took me back a bit, if we're trying to look at best use of money. And can I say that the idea that we will now get to a position where we would have 11 months paid in 1 month is very, very good. I think that's, so we're always at you about things, that are going wrong. I think that is very, very good. Although it would have been better if we'd been able to do this at an earlier stage, because I do believe, and I spent last Thursday morning in A&E in Craigavon. It was quite brutal, the conditions there that staff are working in. I think we need to acknowledge the work that they do, and I think that's really important. I suppose towards the end of this year's accounts, I've seen figures which say that in 18-19 health had a £32 million underspend, 19-20 a 69 million underspend, 21-22, 25, 22-23 a 27. I don't have a figure for 23-24. Are you anticipating? Well, those are hefty underspends given the issues. Now I understand it's a huge budget, and it's difficult to make all the assumptions that you must do as you start to plan for the budget. But are we anticipating an underspend now?
So it's impossible.
Or an overspend?
Yeah, it's impossible to land, a budget the size of health on exactly on zero. I think the underspend last year was certainly single figure millions. I think it was less than 5 million for 23-24. Yeah. We're always conscious that in a normal year there is the ability in the budget exchange scheme to carry money forward into the following financial year, and we would obviously much rather do that than spend it on something unnecessary just to use up money at the end of the financial year. This year, we will still be looking for that remaining month all the way up to the end of the year. And on that basis, I would expect us not to have a significant underspend this year, or indeed an overspend. Okay. No, well, it's. But it will not be zero.
I have, to be fair, I've heard the health minister said the importance of not having an overspend. That's massive for the whole spending picture in Northern Ireland altogether. But I think that it is important that we're utilising the budget. Just on the 1.5 million for waiting list, do you have any sense, or could someone maybe just write to the committee about the level of activity that 1.5 million will actually bring? I think that
if we receive it, I think it's in the bid detail that you'll have received. I think, off the top of my head, I think it's 125 procedures. Sorry, 125 patients for primary joint replacements in the Western Health and Social Care Trust, if that were to be received.
So that's hips, knees, that kind of, yeah. Okay. That's fine. In terms of how you account for money, I received an answer to a question that I had written. And this is important given the issues around the maternity hospital, that in the critical care building, the Belfast Health and Social Care Trust, after handover, had to then spend an additional 14 million in that. Where would that, no, so that would be phase 2 of the critical care building, the helipad, medical records store. Anyway, as it goes on, where would that money have come from? Is that a capital expenditure from the department, or is it a trust expenditure?
So, ultimately it will all be from the block and from the department, the allocation, but I don't have the exact details of where that 14 million was funded from. But it will be, when we allocate the budget every year, we will give the trust a pot of money. Each trust gets a pot of money for general capital. They usually use that to replace equipment and things that are end of life. They also will use it to do minor estate works. So I don't know exactly what amount it is you're referring to there, but but it could have been a combination of two, is what I'm trying to say. It could have been a combination of things they funded from their general capital allocation and potentially bids that were submitted to the department to find within the wider capital budget.
Peter, would you write to me just with the detail on that? I'd really appreciate that,
So
because I think it's important that after we hand over a building, that there isn't additional money required, or a lot of it. I'm sure there's always something it's like everything that we do. There's always something going to be required. I accept that entirely, but
14 million for the critical care building. Did you say?
Yes. So it's 14 million.
Do you have an AQ reference number there?
I do indeed.
Oh, great. Yeah.
16684.
Okay.
So that would be very useful indeed. I think that's it, Chair. Thank you.
Good, thanks, Dan. Linda?
Thank you, Chair. Can you hear me okay?
Yeah.
Thanks very much. Just a couple of points. The first one is around the cross-border directive and that reimbursement scheme. I'm just wondering, was there specific reference to that in any bid that was put into the finance? Or is that just part of the overall waiting? I know previously it was part of the overall waiting list initiatives, or potentially going to be part of the overall waiting list initiatives. Is that still the case?
That would still be the case. I mean, I think picking up on Nuala's point, I'm not sure that our policy colleagues would necessarily see it as the highest priority, because they're trying to make sure that funding is diverted to those of greatest need. But it certainly would be an avenue that could be explored if we had funding.
Yeah, and I agree. And sorry, there's a bit of feedback. For all the reasons that Nuala actually said, you wouldn't want it to be the highest priority, because we actually want to make sure that people who need it get it, and that it's not based on whether you can afford to front up and then be reliant on money coming back. And very often it's people who can't afford to front up. They're going and borrowing money from anybody they can in order to get that surgery for a number of reasons, to get back into work and all sorts of things. So I still think, I'm thinking of that issue that you raised around the difficulty in spending money late in the year, in the financial year. Sometimes you have to be innovative. Sometimes you have to look at how can we spend money quickly. And I think that in that, everything should be looked at. And I always talk to groups and organisations and voluntary groups and organisations out there, and I say, be shovel ready. And that's not always around capital. It's just an expression. You know, be ready to go, have something ready if you really, and if the money becomes available somewhere, then we might have a chance at the end of the year. And that's happened on loads of occasions. So I suppose it's about trying to be as innovative as we can and try to spend every penny to make sure that best use is made of it. That's not to say waste. That's not to say spend on things just for the sake of spending. So just to clarify that, I suppose just this is more of a point, you know, efficiency obviously is very different to redirecting how we spend the resources that we have. And in fairness to you, I mean, you're here on the budget, and policy decisions are not yours. I get that, but I mean, I think the point does need to be made that everything is actually not about efficiency. Spending less is not always about efficiency. Sometimes it is about actually better use of resource. So for example, you know, we know what causes winter pressures. We've been told it time and time again. It's front door, A&E, doors open all day, every day, people coming in, beds being blocked, but no back door open, so people not being able to get out. So at what point are we going to actually say we're going to invest the money into our social care, knowing full well if we invest properly in it, if we really take this seriously, then we won't end up needing the additional beds in the hospitals next year, because we'll actually be able to get people out into the community. So is the Minister having those conversations with you around the budget?
So I think the Minister had said that he is looking at moving to the real living wage in 25-26 as part of his determination to invest more in social care. I mean, obviously that's not going to be without its challenges in the budget environment we're in, but that is certainly factored into the financial plan that we have put forward for consultation. Albeit
no, and he has said that. Yeah, he has said that, and I really appreciate that, and I think it is really good news for those staff out there. But everything comes with we need additional money, and don't get me wrong, I'm not for 1 second saying we don't. We absolutely do. But there will be massive savings if we can get people out of hospital on time. So I think there needs to be just a wee bit of more thinking, a wee bit more conversation. And I know that's at risk. I don't underestimate the challenges and difficulties that you have, because it is massive. It is massive, and health has the budget it has because of the absolute immensity of it. So I understand all of that. I absolutely accept the difficulties you have, but I really think that we need to start doing this, and we will absolutely do what we can to support the officials, the department, the minister in that, because people are telling us the solutions. We need to be listening to them. I just think that point needs to be made. My last point is just, and again, it's more of a point. We talked about BSO in relation to the can't even think what I'm talking about now. In relation to the PPE. So are we? And I know it was said, I'm sure BSO are doing everything. I'm sure they are, but are they reaching out to others for ideas? So there are lots and lots of charities out there, and the first one that comes to my mind is, for example, those that do the street work with people who have drug and alcohol addiction, and a lot of them have to wear PPE, and these are unfunded charities very often, not given any funding from any government sector. They have to wear PPE because they are dealing with people with all sorts of complex issues. And that's they're going out and reaching out and begging and borrowing to be able to fund that. So are BSO doing things like that? Are they reaching out to those charitable sectors that aren't funded by health and don't necessarily have a funding relationship with them? But if they have PPE that can be used by those charities, then use it. Don't let it be disposed of unnecessarily. So I just think maybe widen out who they're talking to, who they're having conversations with. Maybe they're already doing that, but we can say I'm sure, but none of us can be sure unless we get that information. So I think the chair has already said we'll ask for some information back on that. And again, we want to be helpful in that, because when I'm saying widen it out, it's only so that we can give suggestions that if you're sitting in a room of 2 people, you may not think of something that you'll think of in a room of 10 people, no matter who those 2 or 10 are, or what they know or what they don't know. We'll all, more heads thinking about these things will always be better. So I just want to make that as a recommendation. I just would hate to see PPE being disposed of. And, Nuala and others referred to the GPs and the care homes. I think that probably is an area that BSO definitely will think of. I'd be really worried if that wasn't in their heads immediately, but maybe not that wider issue. And then even thinking are there opportunities for sending it to other places, other countries, charity, bigger charities. I'm not even talking about necessarily just local. I'm just throwing that in there as an idea, and then if we can get feedback on that, on how that is happening and what work has been done in that sphere, not from yourselves. I understand that come BSO.
Yeah, no, and I do think getting that from BSO, but I know the sorts of things you're talking about are things that certainly I haven't had any direct conversations with BSO on this for some time, but I know when those were the sorts of things that they were thinking about. But nevertheless, I think you're best to get the briefing from them.
Yeah, no, that's helpful, Bridget, and I know that I think some of these things had been raised with you before, even before the assembly was back up. So I know that some work was being done on that. Chair, that's me. Thank you very much.
Thank you, Linda. Alan Robinson.
Thanks, Chair. Just looking ahead to the next year's budget and the 400 million funding shortfall or projected gap. You'd indicated, Bridget, that of that 400 million, that 76 million was for waiting lists. Is that correct?
So it's not just quite as straightforward as that. So we have a list of additional funding requirements, and then we have a certain amount of funding. And so there's a difference between our list of requirements and the amount of funding we have. So that 76 million is in our list of requirements. It's not necessarily in the 400 million, if you see what I mean. The 400 million is the difference between a longer list of requirements and the amount of funding that we've been allocated, if that makes sense.
I don't know. Just on the back of that 400 million, and I may have missed it, there's a wealth of paperwork that we get every week. What is the breakdown of that 400 million? What is the detail, and how much of that is as a result of the GP or the national insurance increase?
So again, it's back to the fact that there's that longer list, and it is in the EQIA document, which I think hopefully has been sent to yourselves, but I can certainly give you the national insurance for third parties, which is GPs, pharmacists, care homes, a range of organisations. That's in the plan at 36.5 million.
Is there any, what the rest of the detail on the 400 million?
So, as I say, I have got it's a list of so effectively we have a list of pressures that brings us to a funding projected funding requirement of just over £1 billion, and then we've got 600 odd million of funding against that. So the 400 million is the gap. I mean, I've a list of 10 or 15 items here. It is in that EQIA that will be with
no,
you.
We'll leave it now. We're conscious of time.
But obviously, if that's not clear in the EQIA, do obviously feel free to write to us, and we can clarify.
Okay, on Chambers.
Thanks very much, Chair. Bridget, at the beginning of your presentation, you used a phrase that I'm very familiar with in the grocery trade. I think you maybe stole it from us. Better looking at it than looking for it. And that would be a mantra that we bring to when we do our ordering. But during the crisis, I remember PPE was a big issue. And we were encouraging officials to reach out all around the world to try and obtain supplies. We were probably paying top dollar. We were probably involved in bidding wars to get it. But certainly the encouragement was there for the department, get it at any cost because we need it. It's life and death. And the emergency planning, in my recollection, emergency planning really was coming from a collective within the executive. So the pressure to bring in emergency supplies like PPE probably would have been coming from that sort of emergency planning rather than maybe directly from within an individual within your department. But if you'd run out of PPE during the COVID crisis, would you envisage that the conversations in this committee around the topic might have been coming from a different angle? And Colin referenced the North-South scheme, reimbursement scheme, hugely successful. A lot of people in Northern Ireland now out of pain and because of that scheme, and very grateful to it. My understanding, it was a lack of funding, run out of funding, and ceased. But can you confirm when the Assembly returned last year that there was a bid of £31 million made specifically for hips and knee replacements, but that bid wasn't accepted? And my third point is recently you'll have noticed a lot of motions coming through the Assembly directed at health. And many of them been promoted by parties who sit on the executive, and I'm sure would understand the budget pressures that are the reality. But still, these motions are coming through, and they're asking for new services, they're asking for enhancement of services, all very commendable, and we'd all love to see them maybe being in place. But I struggle to get my head round to see where the funding for all these wish lists would come from. Can you help me?
Yeah, I'll try and unpick that, Alan, a little bit. I mean, I think certainly, back to the rather looking at it than looking for it. That is the reason we got ourselves to the position where we had a significant stockpile that is now expiring, is because we did take the attitude and as you say, I think supported at the time universally, that we needed to get hold of PPE because we didn't want our health and social care workers or indeed the wider health system to go unprotected. So yes, I think it's easy in hindsight to say, should we have bought yet less? Yes, absolutely, with hindsight.
Well, it was a heck of a good investment at the time.
At the time, yes, knowing that we had it there, and indeed securing the supply into the future, because we didn't know how long the pandemic was going to last. You know, if it had taken longer for a vaccine to be developed, we had secured that supply into the future. Your second point was around waiting lists. I'm afraid I don't recall the specifics of our bids, but certainly we had bid for a significant amount of money in the 24-25 budget, and I think there was an allocation made of around 34 million that was ring-fenced from the Westminster government, and that was the only specific allocation that we received for waiting lists. We then supplemented that from within general allocations, at the expense perhaps of other things that we would otherwise have done. And then your final point, yes, I mean, we are struggling with this budget to fund what we're currently doing. And I think, as you alluded to, I said in my opening remarks, the increase in cost of delivering what we're currently delivering is outstripping the pace of increase in our budget. So it's hard to see how we then also fund additional services on top of that.
Thank you.
Thank you, Alan. Did you want to come in quickly? Okay. Thank you to all of you for coming today. And again, it's always very, very helpful to us to get the detail needed. And I suppose we'll anything that we've raised today, we'll look forward to hearing some updates. Danny, quickly.
I just make one comment just on something you said that really stayed with me, that we may be approaching a time when the Minister will have to choose between services and staff. That's a very shocking thing to hear, and I would say that's not the choice. Without staff, there is no service, and we should be keeping that in mind. So,
I completely accept that point. Yes.
Thank you. Members, just one suggestion I would like to make. I think, particularly given the Minister's comments in the letter that we've received, and I know he is sharing that with other executive colleagues as well, in relation to the budget, and I know the officials have outlined that we're looking at a budget for 25-26 with a 400 million shortfall. We can go round and round in circles all day long about how much the executive should or could be given to health, but the reality is, and we've seen that very clearly by we're almost at year end here, that we'll never be able to meet that even with the existing budget. So my suggestion would be to write to the Minister to ask him what his intentions are in terms of engagement with Westminster, to make the case for additional funding, because I think we, as an Assembly, are united in that we agree that is what is required, and I'm hoping that will be done in conjunction with executive colleagues, because I think in order for us to square this circle, I think that's the only way we're going to get any headway in terms of addressing the fundamental issues that we're seeing week on week. And I suppose, as the Minister has outlined, that and we've heard this from the various representatives, officials that we have had in to committee over the last year, they can't rely on last minute funding. They need the ability to plan, and we can't do that without the funding at the start of the year. So if members are in agreement to do that, to kind of get a sense of what the plan is around lobbying for additional funding, rightly so, that we're entitled to.
Chair, is there a protocol, something in the back of my mind about it happened over recent months, but there's some protocol about who can actually approach the Treasury in London to ask for funding? I'm not sure whether it's that the Finance Minister is the appropriate person to speak to Westminster, or whether it's the First Minister. I'm not sure. I think it might be Finance.
Well,
authority,
look,
but
if that's
it might
the case,
it might be something better checking out just what the process before we ask an individual minister to go forward.
Oh,
I think
and
we
I
do need
suppose,
to do it. By the way, I think we do need to do it. But we need
I suppose
to get
the
it
point,
right.
I take your point, Alan. I think that what I suppose, and I'm not saying the Minister has to go and make his own case. It's about making sure that is reaching where it needs to reach. So in terms of engagement with counterparts across the water, but also with executive colleagues to come together collectively to make that call. I've got Linda and Colin.
I think that collective is vital, Chair. You're absolutely right. and Alan's right in that, but actually it's not, an individual minister absolutely can make their case. Alan, I know the case you're talking about is where there was a wee bit of back and forth between the Justice Minister and the Chief Constable. And that is because the Chief Constable does not get funding from Westminster, he gets funding from the Justice Minister. So that was where the issue was there, and I think in the round it wasn't really that big of an issue at all, because nobody should be biting back at anybody for asking Westminster for more money. We all are well aware that we're underfunded, we're not funded to need. So I don't think there's an issue with the Health Minister, but we absolutely would all be supporting him in that, and all ministers should, and I don't think they would have any. They've been very clear and are on the record as supporting him, his need for additional resource.
Yeah, Colin?
Thank you very much, Chair. Chair, just a couple of points. Number one, I think also, can we maybe ask as well of whoever it is about the ability for 3-year budgets? Because I think if we look at the amount of time and effort that is actually invested by officials trying to plan for 1 year, having to get in-year money, then allocate 1 year money, not get half of it funded, and then go through the same process year after year, I think a 3-year budget would certainly help the department to be able to plan a bit better for those things, if we can maybe see where we are in that process. And just maybe while I'm unmuted and to save going through it again, in terms of the PPE, as a follow-up, that could we ask about when the PPE was actually purchased as opposed to when it's sell-by date? Because we're focusing a lot on that it runs out this year, runs out next year. But I do think if it was a case that it was purchased during the pandemic and maybe runs out next year or the year after, I do think we will have to reflect, because I remember quite clearly at the time all parties were queuing up to get into the chamber to demand that there was PPE purchased and bought. And I think if it was like it was bought this year but runs out next year, we'd say, well, why are you buying so much this year if it's not needed? But if it was bought during the pandemic dates, I think then we have to accept that there was all party were actually calling for that PPE, and even going to factories and discussing taking over factories in order to produce PPE at a time. So that purchase date rather than the expiry date would be important. Just finally, I don't know if Linda's suffering the same. It's actually really difficult today to hear the proceedings. I can hear Linda really clearly, but I'm very struggling to hear the presenters. I don't know if there's just a wee switch somewhere in the settings that could be turned up, but if that could be looked at, it'd be really appreciated. Thank you.
Jonathan's nodding there, so we'll hopefully get that fixed fairly quickly, Colin. Thank you both. Okay, members, I'm conscious we are really far over time, so I'm going to have to be very strict in the next session, if people can just bear that in mind, because we still have a couple of briefings. We're currently probably about 40 minutes over. So our next briefing is in relation to the inquiry on access to palliative care services. You've received a written briefing from the department on page 34 of your pack. As I said, I think I'll have about 30 minutes. We'll see how it goes, but if members can just try and keep questions brief where possible, and I'll do the same. Hello, Gold. How are you? You're all very welcome, and apologies for the delay. It seems to be standard in this committee. We've lots of questions for you, and we'll keep you here all day. I'm only joking. You're all very welcome. In attendance we have Gro Cassidy, Director of Primary Care, Roger Kennedy, Programme Director for Community Care Directorate, and Ram Wilson, Director of Secondary Care. So we probably have about 30 minutes, just because our last session did run over unexpectedly, but we'll gauge it, and it will be covered by Hansard. So if you want to make a few opening remarks, and then we'll keep
it brief in the opening remarks and just try to get the questions as quickly as possible.
So, thank you,
good afternoon, everyone, and just thanks for the opportunity to come here today to brief you on palliative care. We're aware of your ongoing inquiry in relation to adult and children's services, and so we're represented by policies from both sides. We've got adult and children's represented here. I'm Gro Cassidy, I'm Director of Primary Care in the department, and I've got policy responsibility for adult palliative care and hospice services, joined by Roger Kennedy from the Community Care Director of SPPG. Roger has responsibility for commissioning of adult specialist palliative care and hospice services. My colleague Ryan is Director of Secondary Care, and he has policy responsibility for children's palliative and hospice services. Ryan will provide a few remarks separately from me. Members should have received a paper from us in advance of today's session, which provides an overview of palliative care for both adults and children and young people. In terms of adult palliative care, as you know, this is based around a holistic approach that incorporates management of physical symptoms, but also providing emotional, spiritual, social and psychological support to the person and support for families and carers. Palliative care may be appropriate for a number of years. A person may have extended periods of being well and may move in and out of palliative care services as their needs change. Most palliative care is generalist, provided by core health teams in primary and community settings, hospital units and wards. When a person has unresolved complex symptoms and more demanding care needs which require additional expertise and can't be managed by the core teams, this would be provided by specialist services, including inpatient, hospice and specialist palliative care units, as well as specialist community teams. The Palliative Care and Partnership Programme provides regional direction for palliative and end-of-life care for adults in Northern Ireland, supporting the further development of palliative and end-of-life care. The Department recognises that as the population increases, with more people living longer and with more complex conditions, the demand and need for palliative care will continue to grow. It's important, therefore, that the Department ensures that palliative care services are planned and designed to meet demand and need. On the 19th of December, Minister Nesbitt met with representatives from Hospice UK and the Hospice Alliance of Northern Ireland. At that meeting, Minister advised that we'd be undertaking a scoping exercise this year to look at the current status of palliative care in Northern Ireland and assess palliative care needs to help identify gaps and potential opportunities going forward. The outcome of this exercise would inform future planning and commissioning of adult palliative services across the region, including specialist services and hospices. We'll be engaging with stakeholders, including the hospices, as part of that scoping exercise, including on the design of the scope. So it's very early days on that piece. We're happy to explore adult services with you in more detail and take any questions you may have. In the meantime, I'll hand over to Ryan to give an overview on the children's side.
Thank you, Gerard. Thank you, Chair and members. And likewise, in relation to palliative and end-of-life care for children, the Department's policy is broadly to facilitate regional collaboration to ensure that these services are planned and delivered to meet growing demand and increasing complexity of needs. There are some important differences to note just ahead of our discussion today. So for children, palliative care begins when a life-limiting or life-threatening condition is diagnosed, and that may be during pregnancy, at birth or later in childhood, and it continues throughout the child's life and death. And while many will sadly pass away during the first year of life, palliative care can be extended over extended periods, sometimes longer than 20 years. Palliative care focuses on several aspects of enhancing a child's life and supporting their family. So it includes the management of symptoms, the provision of short breaks, end-of-life care, and bereavement care. So for the purposes of today's briefing, and in general, when we talk about children's palliative care, we're talking about not up to 19 years. The total number of children with a life-limiting or a life-threatening condition in any year varies, and it is very difficult to quantify, but was estimated at approximately 2,100 in 2020, and there's an assumed growth of around 2% per year. So it would be estimated at around 2,300 children in total currently within that age band of 0 to 19. Of these, a large proportion, on average about 45 to 50%, are in the under 1 year age band, and there are sadly around 150 deaths per year. We're conscious that today we may be talking about what's a very sensitive and important issue in terms of numbers and statistics, and unfortunately that's the nature of policy briefing sometimes, but we would like to say at the outset, on behalf of colleagues and myself, we recognise that we're talking about individual patients with very complex care needs and families that are impacted for life by the quality of the experience that they have when a loved one is on a palliative or end-of-life pathway. So patient and family voices are extremely valuable and integral to the delivery of care at the hospital and community and hospice level, and also to us as policy makers in the department. So children's palliative and end-of-life care is a core health and social care service, with the majority of care being provided by the 5 health and social care trusts in the community, in hospitals and in patients' homes, and supported by the community and voluntary sector, which provides short breaks and some specialist care through a number of charity organisations. In addition, a paediatric palliative and life-limited nurse is employed by the Northern Ireland Children's Hospice and based at the Royal Belfast Hospital for sick children. The current departmental strategy for children's palliative and end-of-life care was published in 2016 with 23 objectives, which continue to provide the strategic direction to commissioners and to providers of these services. The aim of the strategy is to provide high quality, safe, sustainable and appropriate palliative and end-of-life care to ensure the best possible outcome for the child and their family. One of the key developments coming out of that strategy has been the establishment of a regional paediatric palliative care network in 2019. And that's the main vehicle for implementing the strategy through regional collaboration across the statutory, community and voluntary sectors. The network is well supported by very dedicated staff from right across the system, with membership including palliative care leads from across the 5 trusts, allied health and pharmacy leads, as well as Macmillan and the Northern Ireland Children's Hospice. Its main role is to take forward the priority objectives from the strategy to develop and share best practice. And to date, the key achievements have been the development of antenatal care pathways, rapid discharge plans, an eco-learning platform in conjunction with the Children's Hospice, and the development of links with Republic of Ireland colleagues. I would just like to advise the committee before I finish, in addition to the briefing paper that you've received for today, the Public Health Agency has recently completed a needs assessment in relation to the provision of short breaks for children. That has not been shared with you at this stage because it's just going through some final sign-off processes. But the authors at the Public Health Committee have advised me that they'd be content to share this later with you as part of this ongoing inquiry. So in summary, that needs assessment looks across all the providers of short breaks and makes recommendations on how this service could be enhanced and provided on a more equitable basis across the region. As Garoda says, we welcome the opportunity for this initial dialogue with the committee and happy to answer any questions that you may have at this stage.
Okay, thank you both for that. I suppose just on the back of your remarks, Ryan, in relation to children's, I mean, you'll not be surprised one of the key issues, and it's probably one of the things that prompted us in terms of this inquiry, is what I see as a disparity in the level of funding provided for children's hospice and adults. And I think it's currently 50-50 for adults and 30% for children's. And I mean, the evidence I've had numerous engagements with the Children's Hospice, as of others, and that is, we're seeing, given the increase in need, but growing cost pressures, we're seeing the implications of that, and that has been well documented as well. Which I've probably highlighted, I think I've raised it with both the previous minister as well and the current minister. There was an agreement from dating back to 2004 around the 50-50 funding. Now, looking at that letter, I think it was, I'm not sure who the minister or who was in charge at that time was. It's long before my time, but it doesn't state clearly that is specific to adult hospice services. So is there any clarity as to why there is that disparity, why children's are only receiving 30%?
I think it relates to, I mean, there are some differences in the nature of the services and the demand for those and how they're provided. So that there are different aspects of the services that are commissioned from the Children's Hospice. I would say, firstly, it's helpful to think of the overall level of provision across the system, of which the Children's Hospice is a vital and valued part of that landscape. The 30% that you referred to relates to the provision of bed days and inpatient beds for things like respite care and short breaks. So that's what the department funds there is 30% relative to the cost of those commissioned services, with the remainder being made up by the Children's Hospice. There are other aspects of care which are above 30% and in some cases around 50%. So we can provide a little bit of more detail on that because it's quite nuanced and
yeah, no, I do appreciate that, and I think we probably have had some information in relation to that. I suppose, I mean, from my engagement with the hospice and even with families who have used those services, and this applies, I suppose, to adult hospice as well in terms of the 50-50. It's 50-50 or 30-70 of the commission services, but all I think would argue that is not reality in terms of the cost of providing services, so that's much higher. For me, such an important aspect of healthcare, palliative care, is something that we should not be expecting people to fundraise to be able to deliver. And I know that's not a decision by anybody around this table. This is an historical issue. But I suppose it's just to really emphasise that, particularly when we're seeing, and we've all met with various cancer research organisations, the Cancer Focus, all of those organisations who are presenting week on week figures of increase in numbers, particularly around cancer and other life-limiting and terminal illnesses, which shows that this demand is only going one way. Yet services are having to actually cut what they can provide given the current funding model. So I suppose, in terms, I'm really, really looking forward to hearing the review that the PHA have carried out around short breaks. I think that will be interesting reading to see what they have found given the current status. But is that something the department is looking at? It is the purpose, it is one of the key priorities in terms of our inquiry, what we want to look at and really drill into, because the other side of it is we have seen, particularly in the last number of weeks, palliative patients sitting in corridors. The Minister actually described someone he spoke to in one of the emergency departments he visited, being treated in corridors where they would be much better looked after, in my opinion, if they could get that in the community or in a hospice setting, depending, obviously on their wishes, but I'm sure that they didn't want to be sitting in a chair. So the reason I say that is that's why we really need to emphasise how important these services are, and we really need to revisit this whole funding picture, because I think this is going to get worse if we don't.
Just in response to that, I think it's maybe important to distinguish between the different aspects, the end-of-life care being one important part of that. Your initial question related to the funding for the respite care, and those are different parts of the service provided. When it comes to end-of-life care, there are a number of choices available to families, and maybe the same applies with adults as well. But some of that care can be provided in the hospital. Many will prefer that to be in home where possible, and the Children's Hospice is the only provider of a regional specialist service, which is preferred by some of the families as well. So just to be clear, the needs assessment that I refer to refers just to the short breaks, respite part of the care, and I think it will be of interest to you when that is made available. So there's a hospice at home service provided by Children's Hospice as well, and that is funded at 50% of the commission costs, as is the Palliative and Limited Life Nurse Service, which I referred to as well, also funded on a 50-50 basis. There's family support, including bereavement support, funded at around 41%, and the specialist community team funded at around 43%. The department has worked and engaged very closely with the Children's Hospice since the Assembly returned around this time last year, and this issue sort of came to the fore. So there's been close engagement. My commissioning counterparts who look after the children's side unfortunately haven't been able to be here today, but would be able to provide more detail if needed on the nature of that engagement, but looking very much at the cost of providing all those aspects of care in the Children's Hospice, and what can be done to control those costs. There's also, as we know, huge increases in the cost of generating funds, donated funds by the Children's Hospice and across the charity sector, which is a factor. But I think it's important to be clear as well that the part of the care that relates to respite and short breaks, to bring that up to 50% through that engagement, is estimated at around a cost of about £700,000 a year. Would bring that to a 50-50 level, £700,000 per year in departmental funding. We know that would not, it would make a difference, but it would not relieve all of the financial issues. Yes. Yeah. So that's just in relation to that. What's currently funded on a 30% basis, to bring that to 50 would be something in the region of £700,000 per year, which I think everyone is aware is not available in the department's budget at the minute. But it's important just to be clear that would not completely resolve all of the financial issues that the Children's Hospice faces, as we understand it.
No, and I appreciate that, and it's we've had a very lengthy discussion in the previous session on the budget. However, I do think it's 700,000 in the grand scheme of things isn't a lot of money for the impact that it would make. Plus, for those children and their families who aren't currently able to access services due to the capacity, then because of the shortfall, my feeling is that likely is costing a lot more in other parts of the health service than to try and plug those gaps. And I think that this applies to the broader discussion around palliative care funding and delivery, because I think that what we see where we're able to deliver that really specialised care. I mean, I've spoken to some of the hospices in relation to this, and what they could probably do so obviously, I mean, they have to have all their T's crossed and I's dotted and ensure every single penny is accounted for, which they do. But if they had that security of a more stable funding model, then they could use their fundraising for so much more, which I think 100% would in turn alleviate other pressures elsewhere, but also, most importantly, provide better outcomes for patients and a better quality of life and all of those things. If they're able to recruit more staff to deliver services because they have a more stable funding situation. I think the other pressure that we've seen, given the context of what we've lived through the last number of years, fundraising has become increasingly difficult, which is what has probably led to this real tipping point of where they realised this is unsustainable. So I think that there's all of that too. My only other question, because I know others will have questions, is I recognise that there's different elements of the different services, but I do have concerns that different values, if that's the right, maybe that's not an acceptable term, but different values are placed on different elements of the services, but essentially those services have so much value to the people on the receiving end. And I would be, I suppose, as part of this inquiry, interested to learn more about how we reach, 43% is a very specific amount, and how we get to those points, because I do think that the services are just invaluable. That's the only way I can put it. And I think we should be doing more to try and bring it to a point where they are secure, and they can do as much as possible within their expertise. We talk about in everything we talk about in health, and Grode and others, you've been here before, you'll know we have so much potential, so much expertise in our healthcare workforce right across the board that we are underutilised essentially. But if we can fund it properly and invest where it needs invested, we could be making savings elsewhere, is kind of where I'm coming from.
Yeah, and I wouldn't disagree with any of that. I think the Minister has said himself that if he had funding available, I know he had briefing from our finance colleagues just before now, so you'll appreciate the broader picture. If any funding was available, I think we would like to be in a position to look at how that funding is spent across the piece. The percentages that I've given you are the result of just historic decisions, patterns. Has not been determined that 43% is appropriate. That's just an estimation of what the current proportion of funding is. But 700,000 would make a massive difference in the whole space of palliative and end of life care for children. And as I said earlier, the majority of that care is provided by trusts in hospitals and the community, with the Children's Hospice and other providers being a really key partners in all of that and providing some specialist care. So the engagement that's taken place with our commissioners and the Children's Hospice and the other providers is looking at all of that in the round and taking account of the needs assessment, which will be available to you soon, to provide hopefully a broader picture of all of that, so that future decisions can be more evidence based.
Yeah.
If I can come in with just 2 points just on the adult side. So you've talked about the funding mix for adult side. It's at 50-50. That's again for commissioned services rather than for the cost of delivering those services. I think in relation to changing that as a best, the kind of the composition of that mix. You'll be aware that in the Republic of Ireland they've moved to 100% provision.
Yeah, that was going to be the next point.
At a high level, the cost of that is estimated around €18.5 million. Yeah. It's what they're putting in to support.
And that's adults and children's growth, is it? Is that the full?
I think that's correct, yeah.
Which, €18.5 million, if you even could translate that into sterling, that's not a lot of money for what could be delivered.
Two things are. It's a lot. It's not a lot of money if you have it.
I'm not going to sit here and start making a case for United Ireland, but speak for itself.
And just the other point, just kind of, I'm conscious we are pressed for time. And the other point, just on the potential in palliative care and the potential of hospice. I would agree with a lot of what you said. I mentioned the scoping exercise. One of the purposes of that is to look at what potential is there for. So we want to look at, I guess, a proper audit of what we have in terms of adult provision in community, in hospice, in trusts, because we don't have, we can see the partial picture. This commissioning happens that we're not cited on because the trusts have their own arrangements locally. And that there's an audit piece within it, and there's also a piece on looking at the potential. So looking at say hospital attendances or ED attendances, or looking at what's present in the GP and say, well, could these patients have benefited from an alternative approach? So it's kind of what you're talking about, the weights. And that will, that work, we haven't yet scoped that fully, and we need to engage with the sector to kind of do it properly, but that will give us really good data to base decisions on around where best to invest kind of on the palliative side and also wider than that. And it may not be in hospice directly. It may be that there's more investment in community services was appropriate, or maybe we work with hospice to build their community offering. But it's not just as monolithic a picture as just, it goes to hospice and they provide beds. I think it's much more nuanced than that.
Yeah, no, and anything I think that is delivered, I think should be co-produced anyhow. I mean, in conjunction with what the hospice is. At the end of the day, they are the experts, in my opinion. They know what is best for patients, and they're seeing that every day. So I think that's where it should be coming from. I suppose just to go back, I mean, that was the point I was going to raise. I think it actually makes it very difficult then when hospices and palliative care services here see what's happening in the south. And I say that a bit of a tongue-in-cheek there around the case for United Ireland. I mean, some of the stuff speaks for itself in terms of what you can do when you have the money. But what I'm saying is that it would be interesting as part of our inquiry. We will be visiting St Francis Hospice in the south to see what they do.
The Minister is due to do that as well, and it was rescheduled from before Christmas. They haven't got a new date, but he has been invited and is going down to see. Yeah, so I mean, I would be really keen to see what they're able to do as a result of that funding model, in comparison here. So it is a really, really good place for us to look as well. So thank you for that. Linda?
Thank you, Chair, and thank you to you both for your presentations. I mean, Liz covered a lot of the issues that are out there for people, and particularly for those who are providing services. Just in terms of the scoping exercise, obviously it was originally meant to be a comprehensive review of the service, and due to funding that was scaled down, I suppose, or scaled back, whatever way you want to refer to a scoping exercise. I'm just wondering, in terms of what is actually done in this scoping exercise, what is the difference going to be in terms of what we can actually do, what we can see, what we can deliver, what we are going to get back whenever you have the scoping exercise done?
Yeah, well, I suppose the way I pitched, again, this is, it's to be developed, but at a high level, the idea is that it'll have two major components to it. One is that kind of audit of, probably another term audit, but a kind of a survey landscape review of what the picture is now in terms of what's been provided, across all the sectors in hospice, in community. This is, I should be clarified, this is on the specialist side, because the generalist side, it's impossible to disaggregate, and that's where a lot of the care actually happens. So to get a proper sense of what is being delivered from what we're commissioning, but also what trusts are commissioning, what the hospices are providing that isn't commissioned by either of us, and that's to get a proper sense of what is the current landscape, and then to look at what is the opportunity there for alternative modes of care delivery. So looking at where could patients who didn't avail of palliative care because they were seen in their ED, but could they have benefited from a palliative approach, and what would that look like, and what does that mean from a service delivery point of view? I suppose the difference is, I think when we had previously said about doing the review of adult services, that was again that was, we had got early into the scoping of that piece, and before we had to kind of put it to one side. One of the major focuses in that was going to look specifically at the funding model, at the kind of the 50% model, and there's technical things around what comparators are used for calculating what 50% actually is, and the cost base of that. So that stuff would have been in scope for that other review. That's not currently in scope for this scoping exercise. I mean, I suppose what we're talking about is, if you want to think about it as a precursor to further development, be it further policy development, be it further strategic development, it's a necessary piece of work to really understand both what the reality is currently and what the opportunity would be looking forward.
Yeah,
Sorry.
I was just to add there, I think the scoping work allows us to baseline and understand what's out there. It allows us to understand where the services exist and the geography of that, which is important as well when it comes to access, for example. It allows us to understand skill mix and the whole time equivalence in the workforce as well. So I do think that's an important step to better understanding the gaps or otherwise in our current service provision across all providers.
I absolutely agree, and that is appreciated. When can we expect to see what comes out of that? I'm assuming, hope not wrongly, that we will get access to that as a committee, because it'd be really, obviously, given we're doing an inquiry, if you're doing a scoping exercise.
You know, well, the committee will absolutely be cited on it. I mean, we were looking to get initial engagement and drafting work done in the next few weeks on that. I don't mean at a high level 3 to 6 months for the work. I don't know at this point. It depends really on what's in there. But, and I don't know if that will work with the timing of your inquiry, but certainly if we will be providing the committee with any of the outworkings of that as it's ready.
No, I do appreciate that. I think we absolutely need it, and regardless of the timing of the inquiry, we want to get it, and anything that is coming up as a particular issue, we don't need to wait to the end of the scoping exercise. If there's a specific issue, please let us know, because it will be important in terms of the inquiry that we're carrying out.
I'm sure we'll be invited back in the course of the inquiry, so if we have any findings from that, we can bring up that at that point, so there'll be an opportunity to do that.
No, I think that it is really important, and we do need to get an understanding of what's out there. And I just want to make this point, to make it every time we're talking about this issue, but there needs to be, as well as understanding, the department understanding what's out there as a baseline, everybody needs to understand what's out there. So if GPs, and I'm thinking particularly GPs, because that's your first point of contact, is generally with your GP, and it's the person you'll contact most in relation to any issue in your health. They need to understand what's available to them to refer into. So I said this before, it's not the right word, but it's the more joined up and understanding exactly who does what in the palliative care sphere. So, and particularly whenever families, you know, that they're trying to deal with it themselves, that they understand who does what. So, you know, what the Marie Curie nurses do, what the GP does, what the district nurse does, what the Macmillan does, what your specific consultant, whoever that would be, does. So who's responsible for what? I think we need to find a way. And I've spoken before to the cancer charities, because obviously they have a collective now, which is really good. Now palliative care goes much wider than cancer. I think we need to make that point, because there are many people who don't have cancer who rely on palliative care. But I think that it is important that we have as much of a joined up and an understanding of what is available to everybody. I think the scoping exercise you're doing is probably going to feed into that, so that is important. I don't want to take up any more time, because I know that others will want in on this, and it's a shorter time. Thank you very much. Appreciate the presentation. Thank you, Chair.
Diane.
Thank you. Just a couple of questions. Thank you, Chair. So first of all, I do want to say that Alan and I had a great visit to the Northern Ireland Hospice. It's an exceptional place, and it was very humbling to be there, and so on. I also had a really lovely morning when I attended the Southern Hospice memory event just before Christmas, and it's wonderful to see hospices not just look after those, but look after families for a long time afterwards. And I think we need to give people credit for the enormous effort that is put in to palliative care from those sectors. So this is really the beginning of a journey for me in understanding the legal basis that we provide palliative care on, and also the way that it is provided. So when did the strategy on adult palliative care run out?
I think it's 2010 to 15.
So it's now 2025, and we are 15 years without a strategy on palliative care. Is that right? That's right, yeah. I think that's quite shocking, actually, to be honest. I do think that is quite shocking. And I do think that is why we are where we are, because we don't have a roadmap, we don't have a destination, we don't have a goal, and I think that is quite shocking. I suppose, so I'll probably have dozens of questions, and I'm only going to ask a couple. Don't worry, Chair, I'm only going to ask a couple. So in terms of what you're doing, you're now doing a scoping strategy to try to figure out who does what, where, etc., etc. And again, I must say it's welcome that you're doing it, but it actually is quite shocking that the Department of Health should have to do that with no strategy in place to actually get to that. So a key question from me, my understanding is that in England and Wales, there is a legal requirement on trusts to commission palliative care services, but that there is no legal requirement in Northern Ireland. Is that correct?
Yeah, that's as the 2022 Act brought in that legal requirement for ICBs to commission palliative care services.
But there is no legal requirement in Northern Ireland.
No, well, we commissioned services, sorry, so there wasn't.
No, that's different. Is there a legal requirement to commission services in Northern Ireland?
But rather than misspeak, I'll come back to you on that point of detail.
Yeah,
but,
I think that's very fundamental for the committee to understand, because I think if there is no legal requirement to commission palliative care services, I think that's why they're patchy. To be honest. I think that's why we have a situation that we do have.
I'm happy to come. I'll come back with confirmation that. I think probably clarify as well the legal basis for all commissioning, not just for palliative services. I'm not sure that it's a legal requirement around.
I would just add as a general and broad point, maybe helpful just to say the department has a broader statutory duty to provide. Don't know if it uses the word commission, but to provide health services that are in line with the needs of the population. That goes back to the 1972 HBSS order, which would have been updated by the 1998 Health and Social Care Act, I think. So it's a more general power. I'm not aware there's a specific one in relation to...
That's a general power, but I'm specifically asking about the commissioning of palliative care beds, and there is no legal requirement in Northern Ireland for that. Because if that is the case, I think that that's a brilliant starting point for the committee and the inquiry. I didn't know that until I started to look into it, and I was quite astounded by that fact. If we don't have a legal requirement to commission beds, does that mean, or does that lead us to a situation where we now only 40%, I'm just using general terms, but we 40% fund care for people who are at their most vulnerable and most frail, and for their families? Does it all flow from the fact that we don't legally have?
Well, as I said, I'll
beds?
come back with clarification on that legal point, and without having the answer here, I don't want to misspeak on the subject.
Okay, I think that's really important that we do that. Are we the only part of the United Kingdom without a palliative care strategy? Even the United Kingdom and Ireland, are we the only part without a palliative care strategy?
We are currently. I would say it's not. There is no current strategy in place. That's not that uncommon in health. I'm not saying it's a good outcome, but it's not all that uncommon. Certainly, palliative care is not unique in that sense. And there are structures set up as a result of the previous strategy that have been given strategic oversight to palliative care development and service delivery and development. So I don't think it's the case that this completely has been no strategic direction given. The Palliative Care and Partnership Board, which is a very collaborative group with all the key stakeholders in it, is given that strategic oversight, and you will have seen their work plan and in the papers that were provided to support. So there's a broad programme of work underway on those strategic development and service.
Well, credit to the current minister for starting the work. I think that's absolute credit for starting the work, but I'm quite astounded that we are where we are. Do we have a clinical lead for palliative care in Northern
Ireland? In terms of the Palliative Care and Partnership network, that's co-chaired by the Director of Nursing, the PHA, and the Director of Community Care within SPPG.
Those are very generalist positions, though. Do we have one specifically for palliative care?
We have input from some of our palliative care medical consultants that would sit on the partnership as well, that would sit in our subgroups and advise us in terms of our actions. Yeah.
And just to add to that, in relation to the children's aspect of the service, the regional paediatric palliative care network I mentioned, so there's a clinical lead within each trust. There is also a post for a regional clinical lead, and that's currently vacant as of the last few months, and it's a very specialist post, so we're not clear on when that will be filled, unfortunately, but each trust has its own dedicated clinical lead that leads the staff within that trust. Now, I would say they've received funding that allows them to dedicate one programmed activity, so half a day per week on average, to their contributions to the regional network and collaboration, and that's how a lot of our clinical networks operate. And I think, I know that all of those staff go way over and above what they're commissioned to do, and would do much more than one programmed activity. So that's an area that, were there more investment, a huge difference could be made to increase the level of input that those clinicians have in their lead roles, providing the regional collaboration through the network.
And just finally, Chair, well, not finally, because I'm quite passionate about this aspect of our care. I do think that this is I think a compassionate society should be helping people at their most vulnerable. I genuinely believe that. But in terms of funding, and probably you're not the right people to ask this, so sorry. One, when will your scoping exercise finish? Two, do you know if in the amount of funding allocation being looked at for next year, there will be something to cover the increase in national insurance for services within hospices?
Well, I'll take on the first point. I mean, as I said, we're looking to get the initial work done on the scoping in the next few weeks. Depending on the size and shape of the scoping exercise will determine how long it'll take. But in my mind, I'm thinking 3 to 6 months. But it'll depend on the final shape of the scope. But we'll keep committee sided on that as it develops. In relation to national insurance, I'm sure you've heard from the previous presenters. This presents a serious challenge, not just for the hospice sector, but for wider family health services. We are not expecting additional funding to come for that. Our minister has written to the finance minister to kind of flag his concerns about that, and who has in turn, I understand, raised it with Treasury. We will wait and see what the outcome of the budget is, the final outcome, and it's been raised as a pressure, and it's been identified as something that will need attention.
Thank you. Nuala?
Thank you. Some of my questions were already answered. It was about the gaps. I will have more questions as well whenever we hear and visit more of the hospices and palliative care providers, both at-home providers. I think it's important that we hear back after hearing from them, because they no doubt will have questions for us too. But just in the meantime, following on from some of the questions that Linda asked, and I know that you've provided a briefing, and I've read a lot about it. The public don't get to see the briefings that we have, which is why sometimes we ask questions that are already somewhat answered in our briefings. What exactly exists here in Northern Ireland, let's take children's first, that is 100% funded by the NHS for palliative care for children? What are the options that are 100% funded through the NHS?
So that is all. I referred in my opening remarks to the majority of the care for children and young people being provided by the 5 Health and Social Care Trusts. So all of that is what's funded. I'm not in a position to give you a clear cost of that, because there's multidisciplinary.
It's what? Is it in-hospital care or at-home care?
Well, all of that's led by trusts. So the teams are based within trusts. There's a mixture of hospital-based care. That's management of symptoms right through to more serious and end-of-life care provision. Sometimes that's appropriate to take place in hospital. Sometimes there's the ability to do that in home. There's funding for critical care nursing, which are integral to the network and to the delivery of services as well. And they work both within the hospital, within the community, and in patients' homes. It's a real tapestry of services, and it would be an exercise to try and cost that out. But everything that's trust led is what's fully 100% funded by the department or by the public purse. In addition to that, you have the enhanced level of care and support by community and voluntary sector organisations, including the Children's Hospice, which deliver some core parts of the service, but some added value aspects of services as well. And that's to different degrees. So in addition to the Children's Hospice, you'll see when we are in a position to share the short breaks needs assessment, there's other local providers that provide that in each of the 5 trust areas as well, and those are utilised to different degrees. The paper also shows issues of access and equity in terms of the distribution of those children across the 5 trust areas, and some of those trusts use the Belfast services more or use their own local services more. We need to understand better what the drivers of that are, and sometimes that's individual choice. But sorry, to go back to your question, there's trust-led services 100% funded by the department.
And what then for adults that are 100% provided,
I'll pick that
funded
up.
by 3?
In terms of 100% funded, it would be those trust specialist palliative care services that exist at the moment. But that's not to forget the range of generalist palliative care services that sit across.
So in layman's terms, is it in hospital or at home care, or both?
That'll be a combination of both on those trust services.
Mm-hmm. Okay.
And this is just as you said in the opening remarks, the majority of palliative care is delivered in general services, so it's in your GP, it's in your community nursing team, so you can't disaggregate the palliative element of that funding, but what's delivered as a general service is 100% funded. It's really it's the hospice delivered stuff that's the 50-50 model.
And so people then, that sounds to me that people are choosing to use the hospice services that exist in Northern Ireland because you use the words enhanced level of care. They offer the core parts, but they offer an enhanced level, which sounds to me not, and this is not to speak negatively on any of the people actually providing services, but a better level of care, more care, additional on top of. So has there been an assessment of what actually is the better outcome for the patient, this enhanced or standard? And should it all be should the enhanced actually be the core?
Well, to clarify, when I said enhanced, I mean relative to what's provided as the baseline by the health and social care system. It's delivered in partnership, and I think some service users, Children's Hospice and probably adults hospices, would describe their experiences there as 5-star or like equivalent to a hotel stay, and that's what they're intended to provide. So there's a lot of, but that I would say not to detract from what is provided by our trust. It's an excellent high level of care and provision as well. So when I say enhanced, I didn't mean better. I mean in addition to.
But it's just, I'm struggling to see that there is a difference though between what is baseline and what is provided by the charities. And they rely a lot on their funding, and that we do hear often, and I have visited some of hospices, most recently the Children's Hospice in particular, and patients and families speak very highly of it. We will hopefully be meeting with more people who experience the just trust-led palliative care, but it just already I am seeing evidence leading to that. Those services operated by independent by charities are essentially better, which is just not how it should be. It should be, the standard shouldn't be a baseline in the trust, but actually here you can, if you go to the hospital, it'll be better, you'll be more comfortable. Will the gaps that you're talking about assessing actually look at why it's
Yeah, apologies, but I do think it's important again to distinguish between the short break respite provision, which hospices provide at an excellent high standard. And that by its nature is outside of hospital and outside of the patient's home, so it's intended to be a break.
Yes, no, I understand.
There's an element of choice there for families as well, where if they've had short breaks through their life, they might prefer to, when they get to the end of life stage of care, that's the preferred destination. Many, and probably the majority, would prefer, if possible, to have that end of life care at home, and that is delivered also to an excellent standard, obviously by very dedicated staff. Could be enhanced with more investment, of course, but I really want to be clear. I'm not trying to imply that there's a better or a differential in terms of standard or quality there. I mean, it's what I'm describing is an overall landscape of care which is intended, and the strategies there and the network is intended to make the best of that. It's very suitable to very individualised care needs, and the choice is there for parents. So I'm not sure if I agree with the premise of the question.
I'm talking about children and adults, to be fair, and I think what during the assessment of the gaps, I think it is important to look at why one is picking up or another is kind of missing out on. Why is the charity sector able to deliver enhanced provision in a way that looks different, not just only at the funding costs. It just seems to me that there is this level of care that is so different from what is offered by trusts or
as a department, we don't have visibility on what are the elements of the hospice provision that we don't fund, and that is very much that's correct. That's appropriate. We commission what we commission, and we make sure that they deliver what we've commissioned. So I think that hospices have got some discretion with funds that they've raised through other means. They've got discretion to use those to best effect, and they can maybe be more agile in responding to the needs of individual patients because they have that flexibility. So I mean, I don't know, is that kind of the territory you're talking about?
That is something then worth exploring and hearing back from more then around that, in terms of that flexibility and the ability to be agile with how you spend to meet individual need. To me, palliative care, whether it's supplied by a charity or a trust, should be about very specific individual.
Yeah, well, I mean, so we commission to deliver specific outcomes, and we've got specific kind of limited funding available to deliver those, and that is where we is our responsibility, and that is what we make sure, and that's what we performance manage, or that's the wrong term, but that's what we give accountability for with the hospices and other providers for that.
Yeah, I maybe come at this with slightly different lens, in so much that I am assured that especially palliative care provision is high quality both within the statutory and the voluntary sector, and I think it's important to say that. I think from wearing a planning lens on this, the important challenge for us, and this maybe goes back to Diane's point in terms of certainly the funding, have we enough inpatient beds to meet the specialist care needs of our population? And that through the needs assessment and through this baseline piece of work, and having the beds in the right places for our population as well, to access that specialist care provision when that's required. So maybe coming at that from slightly different.
No, I understand that, because I think it's that I think I may have been misheard wrong. It's not in terms of the quality, it's the enhancement, the add-ons, the extras, the additional things that you have the ability to offer. But it's something that we can explore further when we do actually have it in front of us. I do have a time frame at all. You don't? I think that was asked about.
The scoping piece, like I said,
yeah,
high level 6 months, but we'll keep you posted on that.
Okay. Thank you. Thank you for coming today as well. And I think, as you said, Grody, we will probably have further engagement throughout the process of the inquiry, and we look forward to hearing more from the scoping exercise as well. So appreciate your time today. Thank you.
And I'll come back on your point on the letters. Thank you very much.
Thank you. Members, so items number 7 and 8 I'm going to take together. They are 2 ASORs relating to the misuse of drugs. So the first one is, if I just refer you to the papers, we have the clerk's memo, the SR and an SL1 for SR 2024-222 from page 88 of your pack. And then we also have the clerk's memo, the SR and SL1 for SR 2024-223 from page 104 of your pack. And we have correspondence from the Minister in relation to this at page 67 of tabled papers. So we'll deal with both together. We have officials here to make some brief remarks, and if anyone has any questions, but if we can try and keep it as brief as possible because we are way over time. Hey Gary, how's things? You're all very welcome back, and apologies for the delay today. In attendance we have Canis Ward, Head of Medicines Regulatory Group, Gary Maxwell, Head of Health Development Policy Branch, and Karen Simpson, Head of Medicines Legislation Unit. There's just a few minutes for this section, and if I just would ask if you want to make a few open remarks, and if there's any questions then I can open up. So thank you.
Thank you for the opportunity to brief the Health Committee today on 2 statutory rules relating to the control of a number of dangerous drugs under misuse of drugs legislation. The Misuse of Drugs Amendment Number 2 Regulations Northern Ireland 2024 and the Misuse of Drugs Designation Amendment Number 2 Order Northern Ireland 2024. These SRs were made and laid in the Assembly Business Office on the 19th of December 2024 with a coming into operation date of the 15th of January 2025. This was done to ensure parity with legislation that was being introduced by the Home Office in introducing amendments to the UK Misuse of Drugs Act 1971, along with amendments to their equivalent GB regulations, the Misuse of Drugs Regulations 2001 and the Misuse of Drugs Designation England, Wales and Scotland Order 2015, following the Advisory Council on the Misuse of Drugs ACMD advice on the harms of these substances. I want to apologise for the misunderstanding that led to these 2 statutory rules being laid before the committee considered the 2 SL1s that were originally submitted to the clerk on the 21st of November 2024. I would like to assure you that it was not the intention of officials to deliberately progress with the laying of these SRs without the Health Committee having prior opportunity to consider and scrutinise the policy intent in the respective SL1s. As we have been now made aware of the importance of ensuring that the committee in future should have the opportunity to carry out an informed policy scrutiny of all SRs prior to being made, we will ensure this does not happen again. The purpose of this subordinate legislation is to complement the Misuse of Drugs Act 1971 Amendment Number 2 Order 2024, which applies UK-wide and seeks to control a number of new synthetic opioids which are a substantial current public health threat. They have similar effects to well-known opioids such as morphine and heroin, although some can be more potent. With a high potential for addiction and dependence, lower doses of these substances can lead to the same effects as other opioids. They have an increased risk of accidental overdose, which can lead to life-threatening outcomes. Under the Misuse of Drugs Act, there are a number of nitazenes, another type of synthetic opioid, that are already controlled as Class A drugs. However, more needs to be done to reduce the opportunity for criminals to circumvent existing controls by making minor alterations to the chemical structure of existing named nitazenes under control. The amendments to the Act implements the ACMD proposal to introduce a generic definition of nitazenes. The intention is to future-proof the legislation by covering known and predicted variants likely to present a significant risk to health. The ACMD has published 4 updates to address newly structured related compounds under the definition. Benzodiazepines are sedatives known for use in various treatments including anxiety, insomnia and epilepsy. In recent years, there's been an increase in the non-medical use of novel benzodiazepines. They and related compounds have been associated with a significant health harms. Since the ACMD's last report in 2020, further benzodiazepines and related compounds have been identified that are not controlled under the MDA. As such, the ACMD published a new recommendations in March 2024. The ACMD recommended 15 compounds for control, none of which are licensed as medicines in the UK. As such, in line with the ACMD advice, amendments to the Act seek to control 15 benzodiazepines and related compounds as Class C drugs under the Act. Xylene is a non-opioid tranquilizer that has been approved for use in veterinary medicine. However, there has been an increase both internationally and in the UK in its illicit use. Xylene can dangerously lower an individual's level of consciousness, especially if combined with other sedatives. So a further amendment to the Act seeks to control xylene as a Class C drug as recommended by the ACMD. The Misuse of Drugs Act 1971 Amendment Number 2 Order 2024 also amends the entry for methoxyphenidine to add an additional common name and its full international standardised name. This does not affect the existing control of the substance as a Class B drug, but adds clarity on exactly which drug is controlled, given that there are multiple common names. To complement these amendments to the 1971, which again, as I say, applies UK-wide, amendments are required to both the separate GB and Northern Ireland respective misuse of drugs regulations and respective designation orders to schedule and designate the newly controlled drugs as appropriate. This follows the ACMD advice and will ensure that they will only be available for research or other special purposes under a licence. Therefore, in both the statutory rules in front of you, the 21 substances controlled by the 2024 Order Number 2, along with the nitazines falling under the generic definition, have been added to Schedule 1 to the Misuse of Drugs NI Regulations 2002 and Part 1 of Schedule 1 to the Misuse of Drugs Designation Order 2001, owing to their lack of recognised medicinal value in the UK. Consequently, it will only be possible to lawfully import, export, produce, possess, supply and administer these substances under a licence. As xylene has legitimate use as a veterinary medicine, it will be placed in Schedule 4, Part 1 of the Northern Ireland 2002 Misuse of Drugs Regulations to enable its continued legitimate use. Both sets of statutory rules also amend the entry for methoxyphenidine to add an additional common name and its full international standardised name. This does not affect the existing placement or designation of the substance, but adds clarity on exactly which drug is referred to, given there are multiple common names. These amendments to both the Act and regulations came into force yesterday, the 15th of January 25, across the UK to protect the public against dangerous substances and to ensure appropriate controls are in place. Thank you for listening, and my colleagues and I are happy to answer any questions.
Thank you, Karen. That was a very difficult piece to get through, given all the really complex names there. So, fair play to you for doing that. No, thank you. I have no questions. I think Danny maybe wants to come in.
Yes, thank you very much for that. I appreciate that. Was obviously lots of big drug names there as well. Some of them will be familiar with, the likes of nitazines and things like that are seen as highly dangerous, particularly on the street. The synthetic opioids are very, very worrying to a lot of drug workers who can find them harder to deal with. I think naloxone doesn't work as well with the synthetic opioids as it does with your more traditional heroin and opioids like that. One thing that does occur to me is we keep referring to the 1971 Misuse of Drugs Act. It would appear to me that this is extremely outdated. We're over 50 years since 1971 and a lot has changed in the world of drugs and whatever else, and we are seeing a lot of changes in drug use since then. Certainly across the decades it has changed unrecognisably. It would appear that the 1971 Act is very, very much outdated now. I know it's a reserved matter, so it's not something that we can look at here. But certainly, I think given the amount of drugs that are sadly available in our communities, and we've seen it ourselves, you know, there have been documentaries where people are buying drugs on phones and having them delivered to their houses. You know, our streets are awash with drugs. The current law, the 1971 law, doesn't seem to be working. You know, the way that we're fighting the war on drugs, as it was referred to as, it does not seem to be working. Drugs are very much available, sadly, and people are paying a heavy price. You know, there are criminals who are making huge amounts of money on this, and people are having their lives ruined. Just looking at the figures of drug deaths over the last few years, I know we've talked to families who have lives ruined by this, by losing loved ones to drugs. I think 154 deaths in 2022. I don't think we've higher or more recent figures since. But there clearly is a big issue with having these drugs put onto the Misuse of Drugs Act. It's not working. I think we clearly have to look at something else. I appreciate they are dangerous substances, and it is, as you say, it is about protecting the public from dangerous substances. But that's not working, you know. But I appreciate we have something in the we have a process here to do. We have substances that, you know, are dangerous, and we're putting them onto a system, which is what we're doing today. But it does appear to me that the system is not working, and people are being harmed, and harmed at an alarming rate and an increasing rate, and we certainly have to look at how we're dealing with that. But thank you very much for the presentation.
I was just going to say, no, thank you for that, and that's really helpful. And as you say, the Act is obviously a reserved matter. We have an action in the strategy to work with the Home Office and colleagues to make sure the Act takes account of Northern Ireland's circumstances and reflects those as well. And we're working with the ACMD and others who actually now come to Northern Ireland and hold meetings on a sort of once every couple of years here to hear the local situation. I think that's really helpful. There are a couple of four-nation drug ministerial meetings coming up over the next few months, and I think that's an opportunity again to reflect the fact that Scotland, Wales, England and Northern Ireland's situation needs to be reflected in whatever legislation comes forward, and make sure our case is in that. So just want to let you know we're doing that work at the UK level as well as the work we're doing locally as well.
Yeah, thank you. Orlia?
Thanks very much. And just on the back of what Danny covered there, obviously this process must be followed when there's dangerous substances on the street, and it's right that the amendments have come into place in terms of the regulations. But I completely agree that it's what the more important aspect is, what are we doing to prevent people from dying using these drugs, because by changing a regulation, it's not having any impact on the ground in terms of people that are taking the overdoses. So as you had stated yourselves, we know that these synthetic opioids, that there already is a massive increase in terms of accidental overdoses with people taking them. And it's good to know then, Gary, even that those meetings that are taking place with things that might be working in England, Scotland and Wales. I know that there was a proposal that was submitted a number of months ago in terms of, we spoke about this and spoke to the Minister about it, well, in writing I think. I've only spoke to Mike about it around the rapid drug testing. So I'm not sure where that's sitting. I know that there is initiatives, the urine samples and stuff that you are introducing. There is work that's being done. But again, I think with the rapid drug testing, specifically for these dangerous drugs, would definitely be a game changer, because we know that when they're on the streets and when whatever they're made up with, if they can be tested and that turnaround is there and that alert system can be put in place, which they're using in different parts of Britain and in Dublin, I just think that, and I know again there's cost to it. It's not a massive cost, but there is a cost. But it's going to save lives. So just to have it on the public record, I am going to hopefully it'll probably be with yourselves. I'm going to send Mike a letter in to see if we can get a meeting just to see where that's at. And I know you are trying your best and you are bringing in different initiatives, but that rapid drug testing, in terms of what we're talking about today with them benzos, will make a difference, I think.
So yeah, there's still ongoing conversations about that particular proposal, and there are both legal issues about how that operates, but also the financial issues about, obviously making that, but those conversations are ongoing. I suppose I just wanted to highlight a couple of things. One, as part of needle exchange, we give out testing strips for nitazines so that users can test their substance. They're not perfect in terms of their identification of the substance. There are risks with those, but at least it's an early warning system for those individuals to try and test their substances and see where they sit. So those go out to everybody who uses needle exchange at the moment to try and identify where nitazines work, and we've worked with forensics, and it does seem that they are picking them up in instances where nitazines are there. We can, at the moment, where we have concerns about a substance, get that tested through the PSNI and through the forensic service. So we do have access to testing at the moment where we have specific concerns about those drugs. Those will tend to be alert drugs that are handed in or seized. There's a question earlier, exactly as you said, about the wider, maybe ongoing process of how we test over time, and we're considering those, continuing those conversations as well. So we're not stopped, but it's a difficult conversation just at the moment with the financial situation, but also there are legal implications of the service and how it would operate and how they get the drugs and dispose of the drugs and all those things as well that need to be managed.
No, and I fully appreciate that, Gary. And as I say, it's maybe it's a conversation that we'll take outside of today's meeting and with anyone else in the Health Committee maybe that wants to take part in it. Because I get that we do have the testing system in place at present. I think, is it Wales the drugs get sent to?
Well, so there is Wednos where we can send drugs to Wales, but actually in Northern Ireland, if we identify a drug of concern, we can get that to police, who will get it to forensics for rapid testing, and then we can put out alerts off the back of that. But it's off the basis of a concern rather than necessarily ongoing testing, a prevalent sort of test ongoing. It's more this drug seems to have appeared at a couple of incidents. Is there a specific issue with this substance? And then we can get it tested and information out.
Yeah, but as I say, we'll hopefully pick that up then.
Happy to.
And I'll write into the department, but thanks very much for today.
Thank you, Orlia. Okay, members then, if there's no one else I think is indicated at this point, thank you all for your time today. We do really appreciate it. It's good to get that information as well. So members, just to remind you that both rules are subject to negative procedure, and the examiner of statutory rules has no issues to raise with respect to the SR. So are members then content with the SRs? Yeah, so if I could just ask if members are agreed then that the Committee for Health has considered the SR 2024-222, the Misuse of Drugs Amendment Number 2 Regulations Northern Ireland 2024, and has no objection to the rule. Okay, and then the second one, the Committee for Health has considered SR 2024-223, the Misuse of Drugs Designation Amendment Number 2 Regulations Northern Ireland 2024, and has no objection to the rule. Okay, thank you, members. Okay, our next item at number 9 is the LCM on the tobacco and vapes bill. If I could refer you to the LCM and the correspondence from the Minister at page 120. And there's some background papers from page 136 which you will be familiar with from previous briefings. Members, the plenary debate is expected to take place on Monday the 3rd of February, and the committee was briefed by the department on the LCM in November, on the 14th of November 2024. Are members content with the LCM as laid? Yeah. Just also to ask, are members content then that at next week's committee we consider a draft report just to outline the committee's consideration and include the committee's previous report as an appendix. Okay, thank you. Item number 10 then is our next written briefing on the hospital car parking charges. If I could refer you to the clerk's memo, page 427, and the written briefing at page 429. Does anyone have any comments at this stage? No? Okay, members content to note. Thank you. Item number 11, if I could refer you to the correspondence list at page 474 and correspondence beginning at page 476. A written briefing from the department on waiting lists providing a 6-monthly update is also available at page 89 of your table papers. Has anyone anything to raise at this point, or are we content with the suggested actions? Orlia?
Just very quickly, I was glad to see the update in the correspondence around the lung cancer screening. I know we've talked about it a couple of times in committee, and we've had briefings from SPPG on it and stuff in the past. And I know it's obviously in its infancy, where they're just doing a sort of pilot work to try and scope out what it would entail to introduce it here. But I just think we should really welcome this and stay close to it and really try and encourage that to be progressed, because they're making progress over in England with it, and Scotland and Wales. And again, like that tool, you need the services obviously to match the screening process, but that really would help save lives. So just to keep a wee eye to it.
It was just to concur with that, Orly, and I think, as we talk about anything that can be detected at the earliest possible stage, we'll have a much better outcome in many cases. So yeah, absolutely agree. Okay, Dan.
I just sort of also welcome the letter in terms of the screening review of the Southern Health and Social, where they indicate that the actual review carried out by the Southern Trust is going to be peer reviewed by people from Scotland and Wales, and that there will be a quality assurance of the whole programme from NHS England. I think that is positive. It may not and will not, and I know we're meeting the ladies with letters next week, but it will not answer all of their questions, but it is a positive move in trying to assure women across Northern Ireland that this programme is hugely important and is important for that it's safe and up to date to use. So
yeah,
I
no,
think
absolutely.
that is worth noting.
And we do have the briefing then on this
Yes.
at committee next week as well. So thank you for that, Danny.
Just on 11.10, sorry, the letter from the Health Minister providing the update on the implementation of the Community Pharmacy Strategic Plan about e-pharmacy. It was just to ask, it's not to be prioritised until 2026-27 at the earliest. which obviously is concerning given that we've heard that community pharmacy is a key part of health service reform. I'm wondering if it would be worth writing to the department and asking them what impact this is going to have, this slow delivery is going to have on health service reform in this area.
Yeah, absolutely.
Thank you.
Yeah. On pharmacy, yeah, and we have them on the 6th of March as well in relation to the pharmacy, so that's great, thank you for that, Danny. Okay, are members content then to note or to agree the actions as set out then on the list? Yeah, thank you. Okay, members, item number 12 then, the forward work programme, page 733 of your pack. And just to remind members, as I've alluded to there, next week's meeting will be held at the Southern Trust Boardroom in Monaghan Row in Uri. And we will have a visit before the meeting to Daisy Hill Hospital. Unfortunately, we're not able to offer remote attendance at that meeting, so hopefully if members are able to attend. But please, can I ask, can I just really emphasise, we have obviously a number of various visits, external meetings coming up. Can I really encourage people to get back to the staff on that, because not only does it allow our committee staff to plan, but in a lot of these settings, particularly around the hospice, they're clinical settings and they need to be able to plan around terms of numbers. So can I really urge people to go back at the earliest possible stage. Linda, did you want to come in there?
I do, Chair, and it's actually specifically in relation to that issue that you've just raised. I don't want to be a pain because I know everybody has got diary commitments, but I have policing board every Thursday except for the second Thursday of the month. And I understand that Thursday morning is probably the best time to do things in terms of linking in with the committee, particularly for yourself and the staff. But if we can try, I just have looked at the forward work plan, and because of the current dates that are being set for the visits to hospice, I think it means I would potentially miss every single one of them, and I really don't want to. I suppose it's an issue that I feel strongly about, but I really don't want to miss those visits. I think they're important. I think in order to get an understanding of what to deliver and, you know, how they delivered, that we could, if we can possibly look at trying to change any of them to the second Thursday of the month, or a Wednesday for me, but I know that doesn't suit everybody, so but I really would be keen to get to them, if it's possible. I would really appreciate it.
I think in fairness as well, Linda, that will impact Nuala too, given that you're both on policing board, so I'm going to bring Keith in here.
Yeah, thanks, Chair. Just to say, we have got some dates for the hospice visits on a Wednesday. I think the Southern hospice is on a Wednesday.
I just checked that, Kate. Maybe I've read that wrong, but the Southern Hospice had been changed then to Thursday because it was postponed. But maybe I've read that wrong.
Sorry, we've got it down in that week of the 6th of March, but it is Wednesday the 5th. So it is. So that's on the Wednesday, and then there's also the visit to St Francis's, which is on a Wednesday.
No, and I appreciate that.
We've been trying just to balance, so we have the visits.
I understand that. No, I understand that, but I mean the second Thursday of the month does suit me. So if it's trying to get it in for health committee, I will definitely make sure I keep that Thursday available for potential health committee. So I'll not take anything else for those Thursday mornings, unless I'm made to. But I certainly will try not to, because I do want to do as many of the visits as I can. I know it's not possible for everybody to do them all. I understand that, but appreciate that. I misread that, Keith, so apologies for that.
Okay. Yeah, I think most of them are. I had read that as the Southern area one was on the 6th, but it's the week of the 6th, so I think we had indicated it was potentially going to be the 5th. So thank you. Are members then content to note the briefings is set out in the forward work programme?
Content.
Yeah, thank you. Has anyone anything to raise under any other business? No.
Sure.
Oh, Linda, briefly, quick.
Yeah, I'll be very quick. I don't know if other members have received letters in relation to Dr. Hussam Abu Safia, the Palestinian doctor who has disappeared effectively. And I'm just wondering if the Health Committee would agree that we could maybe write to the Health Minister and potentially the Health Secretary, or the Secretary of State in relation to and the health unions. I think would be beneficial to use any influence they can to appeal to the Israeli government to provide immediate clarification around his whereabouts and his well-being. So specifically seeking confirmation on whether he's been imprisoned, harmed or killed.
I'm happy with that, especially given the ceasefire.
Does this doctor work here? I don't.
No, he's in Palestine.
He's a Palestinian doctor, but he's disappeared. He's a medical doctor who has disappeared.
Emails came through. Yes.
There's been a lot of lobbies, yeah, there has been a lot of lobbies coming through. But given, I suppose, the ceasefire announced, it might be different. Colin?
Yes, Chair. Chair, I think, can we possibly contact the Minister just to ask him about the announcement that was made on the Nolan show this morning that there is going to potentially be a significant restructuring of the senior management of the department, and how maybe that might be something to run past ourselves, or just to get some sense of what's taking place. I think people are just pretty cheesed off and sick that we do executive by media here, and if we maybe could just get some sense that it would be just nice to maybe be updated ourselves before hearing about it live on a radio show.
Yeah, no.
So if there was a way of just clarifying, are there potential changes, and just what the ramifications of those might be?
Yeah, or when we can expect to hear more about that. I suppose we have the Minister in as well on the 6th of February again, so I suppose in advance of that would be good. Yeah, no, I have no problem with that. Okay,
Right, Chair,
Diane?
has that date changed? Was the Minister not in at the end of January?
It was meant to be, but there's been a mix-up in the there's been an issue with the diary, so it was changed to the 6th, but it was changed a month or two ago, so it was.
Yeah. Diane?
I absolutely agree. I mean, I did ask the finance director, had she anticipated an amount of money in next year's budget for such a position as a health SAR, and she clearly either didn't know or wasn't telling, whichever you can choose. So I do think it is actually important that if we're making announcements or hinting at making announcements on the Nolan show, that actually the scrutiny committee of the department and the Minister understands the impact of those announcements, etc., and how those are going to be. I think most people in Northern Ireland probably think that we are overmanaged in the health service with little action. So, you know, I'll be really interested to understand the thinking behind this one.
Okay, no problem, Diane. I'm just trying to hold members because after our next, we have a closed session just very quickly at the end. So just moving on then from AOB, if nobody else has anything to raise in that one, is the date, time and place of next meeting. So as I said, there's the meeting with committee members this Tuesday, 21st of January, 1 p.m. in room 21 with the ladies with letters. And just if you could let the committee office team know if you are able to attend or not. Our next committee meeting, as discussed earlier, is Thursday 23rd of January at 2 p.m. in the Southern Trust boardroom at Monaghan Row in Newry. For item number 15 on strategic planning, are members content to move into closed session to discuss a review?
Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29. Sound.